All right. Good morning, everyone. Good to see everyone. Welcome to the Human Services Committee Forum on HR1 Impacts on Medicaid and SNAP. I'm Jillian Gilchrist, State Representative and co-chair of the Human Services Committee. I hope everyone had a lovely summer. Although this has shed some darkness, right, on our lives and the work we do. So we wanted to have this forum today because there's a lot of misinformation out there that HR1 is not having an impact, but we know it is and it will. And so wanted to bring folks in, experts in the field, so we can learn more about the impact it's already having and what you are planning for. Before we jump right in, I want to turn it over to my co-chair, Senator Lesser, who is on his way in person, but I didn't know if he wanted to say any opening remarks online. I see he unmuted. Go right ahead, Senator.
Thank you, Madam Chair. No, I will be in shortly, and I'll speak after the first presentation.
Wonderful. All right. Well, we have a lot of great people on our agenda today, so we're going to jump right in. So with that, I'd like to invite up the Department of Social Services. We have with us the Director of Medicaid, Bill Halsey, who is going to kick us off. Wonderful. Thank you.
Good morning, everyone. I'm Bill Halsey. I'm the Medicaid Director.
And good morning, I'm Dan Giacomi, Director of Program Oversight and Grants Administration at DSS.
I believe we have a PowerPoint that we're happy to run through and then take questions. Okay, so what we tried to do with this presentation for this morning is to take a perspective from the beneficiary, from the member. And so we're going to run through components of HR1 or the One Big Beautiful Bill Act from that perspective. And we're going to start, if you could advance the slide. Okay, so this is our assessment of the top 9 actions within the bill that impact members. We're going to run through some SNAP components, and then many of them are also Medicaid related. So if you could advance the next slide, please. We also wanted to put a summary of the effective date for these actions. Some of them, as you see, are in effect, and then most of them have future dates as well. Okay, I'm going to turn it over to Dan to kick us off on the SNAP work requirements.
Thanks, Bill. So on this slide, what you see is a breakdown or a comparison of our current state of SNAP requirements versus our future state. This is in specific to what we call able-bodied adults without dependents, or ABOD work requirements that individuals are required to adhere to when receiving SNAP benefits. Current state, it applies to individuals or adults ages 19 through 54. They must prove that they are engaged in 80 or more hours on average per month of work or community engagement. In the future state, what you will note is that that age range is now being increased to age 64 through their 64th year up until they have their 65th birthday. It also has limited exemptions that individuals can meet or provide to allow them to continue receiving SNAP benefits. Currently for ABODs, they are only able to receive SNAP benefits for 3 months out of every 36-month period, unless they're meeting those work requirements or have an exemption. One of the exemptions, which was a significant one, is that it exempted adults that had a child in the household under the age of 18, hence the term without dependents. Currently, HR1, or as a result of HR1, that exemption was reduced down to the age of 14. So now individuals that may have a child in the home age 14 through 18 would be required to meet these work requirements or present another exemption in order to continue receiving SNAP benefits. Another change that you'll see there is a fairly recent one that was enacted as a result of a previous Consolidated Appropriations Act, where it exempted individuals that were veterans or those that served in the armed forces, regardless of discharge status, those experiencing homelessness, and those under the age of 24 who aged out of foster care at age 18. As a result of HR1, all of those exemptions are currently being removed and will no longer be allowable exemptions for the ABOD program itself. And another significant change is in ABOD, it allowed us to look at the current status of jobs within the state of Connecticut, specifically to counties or different areas or towns, to identify if that area had what we called lack sufficient jobs. We always meant that, or we always took that as that the area itself had an unemployment rate 20% higher than whatever the national average of unemployment rate was. There was a secondary piece of that that said if the town or area had an unemployment rate over 10%, they were automatically exempt regardless of what the national unemployment rate is. As a result of HR1, they removed that first exemption, the ability to look at specific towns or areas and compare their unemployment rate to the national average, and now said that you can only exempt a town or an area if that town or area has an unemployment rate of greater than 10%. For a little bit of context to this, I believe there's only less than 10 counties throughout the nation that have an unemployment rate of greater than 10% at this point. Next slide, please. Another significant SNAP change that you'll see further along in the deck as well, that is a change for the Medicaid program as well, is changes for certain non-citizens. Current state, there are many classifications of non-citizens that can qualify for SNAP. Some after a defined waiting period of 5 years, some kind of immediately upon entry into the state or into the country, depending on their status. So what we've done here is listed out a number of the exempt categories, though not all inclusive of all of the categories we exempt. But you'll see that it contains refugees, asylees, victims of trafficking, those that may have been a victim of domestic violence, either in their home country or currently in the state of Connecticut, as well as COFA citizens or Compact of Free Association, which are those from the Marshall Islands or the Republic of Palau who lawfully reside, as well as Iraqi or Afghani special immigrant visas, who are individuals that primarily worked with the United States government when in their home country, oftentimes as interpreters for our military or other dignitaries that we're visiting. As a result of HR1, many, if not most of those exempt categories of individuals are no longer eligible to receive SNAP benefits. It restricts SNAP eligibility to only lawful permanent residents, Cuban Haitian entrants, and those COFA citizens that I mentioned earlier. So we will no longer be able to exempt refugees, asylees, those that have been a victim of domestic violence, those that are victims of trafficking, or those special immigrant visas, amongst others. Next slide, please. And I believe the final one for SNAP is an elimination of the SNAP Ed funding. SNAP Ed is our primary nutrition and obesity prevention program that we operate through the SNAP program. We have a allotment annually of $4.6 million approximately in the SNAP Ed program that we receive from the federal government. The goal of SNAP Ed, as you can see on the screen, is to help families improve healthy eating choices, increase physical activity, plan culturally appropriate meals, and shop on a budget. We operate this program through a partnership with 5 what we call implementing agencies, 3 of which are through the UConn system, 1 with the Department of Public Health, and 1 with the Hispanic Health Council. Originally, or the original version of the HR1 bill eliminated the program completely, though the finalized budget or bill itself kept the program intact, but defunded the program effective 9/30/2025. So although there is the opportunity perhaps through a future reconciliation or budget bill to add funds back to the program, there currently is no funding available for the program. Our federal partners have told us that we can use any carryover funding to operate the program either in full or a part of FY26. So that is the plan that we submitted, would be to operate utilizing carryover funding in the SNAP program, but it would be about 1/10 of what we receive annually. Now I'm going to turn it over to Bill for the Medicaid piece.
Madam Chair, would you like to pause to take questions on SNAP, or do you want us to run through the whole presentation?
If you could run through the whole presentation,
Yeah,
that'd be great.
sure.
Thank you.
Okay. Okay. On to Medicaid work requirements or community engagement, as it's called within the bill. So, yes, in the current state, so as of now, there is no work or community engagement requirement for Medicaid eligibility in Connecticut. However, effective January 1st, 2027, Husky D enrollees or the expansion population will need to meet work requirements or community engagement rules to get or keep coverage. So the work or income proof of at least 80 hours a month of work or income of at least $580 per month. That's the federal minimum wage multiplied by 80 hours. And then or community engagement proof of at least 80 hours per month of community service or a qualified work or training program enrolled at least half-time in an educational program or any combination of community engagement and work totaling at least 80 hours per month. There is a provision within this bill for a good faith 2-year extension. We don't think that that will be utilized by the federal government that much. They've said that publicly now. So we're really tracking the January 1st, 2027 date as the date of implementation. Okay, next slide, please. There are exemptions. And so for the work requirement or community engagement, so those that are exempt include foster and former foster youth, veterans with rated disabilities, medically frail, for example, blind, disabled, children with serious emotional disturbances, adults with serious mental illness, chronic substance use disorders, serious and complex medical conditions. Again, we probably need more guidance from CMS on this medically frail definition, but that's an example of what it may contain. Alcohol use disorder and substance use disorder, already meeting work requirements for SNAP and TANF, parent caregiver of an individual with a disability, individuals recently released from incarceration for 90 days post-release, certain Native American populations, and short-term hardship waivers. So those are the current exemptions for community engagement. Next slide, please. Along with that is more frequent eligibility verification. So at this time, individuals who are eligible for Husky D must renew their eligibility every 12 months. Effective January 1st, 2027, that goes to every 6 months. So you've got the work requirements or community engagement checks, and then the more frequent eligibility checks for the expansion population. Next slide, please. Medicaid changes for certain non-citizens. Dan referenced this for SNAP, but just to run through the current state, many classifications of non-citizens can qualify for Medicaid or CHIP, including lawful permanent residents, lawful residing children, and pregnant adults within their first 5 years of having legal status, Cuban, Haitian entrants, COFA citizens. So a list of everything on the left is what we currently allow, and then that list just becomes narrower under the new HR1 rule. And then I believe, okay, so then retroactive eligibility. Again, our current state, Connecticut authorized to grant coverage retroactively up to 90 days prior to the date of application for medical coverage. Future state, effective January 1st, 2027, limits retroactive coverage to 1 month prior to application for coverage for Husky D, 2 months for Husky A, B, and C. Again, so just tightening of that window. And last slide, please. And this is the Medicaid member cost sharing. We do not have cost sharing at this time in Medicaid. Future state, this is October 1st, 2028. States must impose cost sharing not to exceed $35 per service on Husky D enrollees with incomes between 100 and 138 of the federal poverty level. Out-of-pocket costs not to exceed 5% of family income. And then there are some exemptions to the cost sharing primary care, mental health, substance use disorder. So again, what we tried to do is convey to everyone today what kind of the member impact might look like related to HR1. happy to take questions.
Great. Thank you so much. And thank you for providing this overview. When it comes to the SNAP Ed programs, would you be able to just give some examples of what on the ground that looks like?
Certainly. The primary example that comes to me, which was a model example that was taken up by a previous administration at the White House, is through the Hispanic Health Council. They actually partner with a number of schools to provide presentations, anecdotally a puppet show for children about healthy eating and staying active in school. Our UConn partners as well have a public website that individuals can go to speak with a nutritionist or a dietitian, as well as find healthy recipes, as well as I said, to learn how to be active or more active within their community, as well as recipes that may be culturally appropriate to the community that they reside in.
Wonderful. Thank you. And then when it comes to work requirements for Medicaid, can you talk through what do we have in place already that would be able to assist us in getting that off the ground? And what do we need to do going forward to prepare for that? And what have you learned from other states so far about what that's going to take?
So thanks for that question. So a lot of this is ongoing work kind of as we speak. So there is some existing interoperability already within our eligibility verification system, say with Department of Labor. But I don't believe we have one with Department of like higher ed to determine if somebody's enrolled in higher education. So that may be an area where we work. So we are really trying to figure out what kind of like IT system upgrades do we need to invest in. And so the feds have talked about a federal data hub or portal, and some states are piloting that, but we think we would need to upgrade our current system or IT system just to pilot that with the federal government in terms of accessing that data hub. But so I think we're trying to put together a comprehensive list of the types of IT and systems and staffing that we would need to build out a eligibility verification system, including the work requirements.
Thank you. Because we have such a fantastic agenda, I'm going to use a rule from our colleagues in the Appropriations Committee and ask folks to limit their questions to 2. So with that, I'll turn it over to Senator Lesser.
I'll do my best, Madam Chair. First of all, thank you for your presentation. And it is clear to me from listening to it and from the research that I've done that a lot of what we were told about President Trump's Republican budget bill just simply is not true. We were told that the cuts were going to go only to undocumented folks. And I'll be honest, I did not hear any mention of undocumented folks. I don't think there are any cuts to undocumented folks in the program. But I do see a lot of cuts to American citizens and to legal immigrants who are paying taxes and working and are being attacked by this legislation. And just on the SNAP side alone, SNAP is our food stamp program. It provides nutrition. We heard cuts to single moms. We heard cuts to America's veterans. We heard cuts to kids coming out of foster care. And we heard cuts, and I cannot think of why we would, as a country, want to go after this population, cuts to survivors of domestic violence and survivors of human trafficking. And maybe the president or his allies could come and share with us why they thought that survivors of human trafficking were a worthy target of their wrath. But those are the victims in this bill, in this law that we're going to have to work with. And on the Medicaid side, maybe Director Halsey, you could elaborate. You know, we think of Medicaid as being a program that takes care of the poor in this country, and it certainly is one. But my understanding, and maybe you could speak to where the dollars go, is that the bulk of the spending, the largest portion of spending, goes to people with disabilities and to the elderly. It's our main way of paying for nursing home care, long-term care in this country. You know, is that correct? I'm just trying to see where the dollars go in the Medicaid program.
Significant amount of dollars go to that population, Senator, correct.
So when we cut Medicaid by over $1 trillion nationally, That was my first question. I can't believe I fell right into it. But when we cut over $1 trillion nationally from Medicaid, what we're really cutting from ultimately, if we're following where the dollars are going, we're cutting our nursing homes, we're cutting services for people with disabilities. And you can try to dance around it, and you could try to come up with all these paperwork requirements about, oh, we're not actually cutting folks. But at the end of the day, we're cutting over $1 trillion from the Medicaid program, and the impact one way or the other will be felt on our nursing homes. I just have one question, though, following up on Representative Gilchrist's question about the data piece, because we're going to have to step up a lot of data to implement things. Now, you mentioned a agreement that you have with the Department of Labor. My understanding is that the Department of Labor gets quarterly reports on payrolls from employers. But the look back period in the Republican budget bill is 1 month, so a quarter won't work. Could Connecticut switch from quarterly to monthly reporting to get you access to make sure that we're not inappropriately throwing people off who are working their earned benefits?
Yeah, unless you know the answer to that, I think we'll take that back, Senator. I think it's a great suggestion.
Yeah, I would agree. I think that would be something that we have to talk to our partners at the Department of Labor to see if they have monthly reporting that they're able to provide to us. Oftentimes, if a payroll provider is providing information to them, it has to be aggregated and entered within their system. So I'm not entirely clear as to whether or not that's something that is feasible.
Yeah, and just to be clear, I know for a fact that DOL does not have that data on a monthly basis right now. They only have quarterly data. But my suggestion is that we look at potentially switching to a monthly system as a way of getting that information. And I think I'm out of questions, but I have a lot more questions.
Great. Thank you, Senator. Representative Comey, followed by Representative Hughes.
Thank you, Madam Chair. Thank you for your presentation. I wanted to talk a little bit today about our benefit cost share and our error rate in the SNAP. We're around 10%, if I remember correctly. And speaking with other states, that is similar to what other states across the country are experiencing. We need to be below 6% to receive the maximum cost share. And then, so I know that errors occur at both the household level and at the state level, acknowledging that. And I know that Rhode Island has actually just submitted a plan, or will be submitting a plan to reduce their error rate to below 6%. Have we been talking about that? Have you been talking about that at that to look at that?
Yes, certainly. That is one of our top priorities right now, is looking at where we can reduce reduce errors within the SNAP program itself. Looking at all pieces of it, similar to what Director Halsey just mentioned regarding technology pieces, to see if there's any additional interfaces with other agencies, whether it be state or federal. Looking at legislative pieces, if there's any flexibilities or changes that need to be made from a policy perspective. Looking at our processes, it's something that we've been pretty much solely focused on day in and day out since the bill itself was first introduced, even prior to its passage, to identify where we can reduce errors. As you rightly pointed out, the errors themselves are both on the state level and on the client level. One clarification that we do like to make is these are not necessarily indicative of fraud, waste, and abuse as is put out there. Oftentimes it could be an administrative or clerical error that causes this to vary. And the threshold for a payment error in the SNAP program is around $50. So if there's a variance in payment from what the individual received, either above or below that $50, we do have to report that. So it's a very low threshold itself, as well as you noted, could be the agency themselves, or as a result of the individual perhaps forgetting to report something or reporting it too late for the quality control standard, which then is held against the state as a payment error.
Thank you. And then I also have an understanding that the standard utility allowance and internet, is been removed. Is that my understanding correct?
Yes, Representative. I believe what you're referring to is the Heat and Eat program. It is something that we do in partnership with our Low Income Heating Assistance Program, or LIHEAP program in the state of Connecticut. We provide individuals that have a shelter cost with a nominal amount of funds that allows us to increase what's called their shelter deduction in the SNAP program, which ultimately would lead to them receiving a higher benefit amount than perhaps without this funding itself. The internet piece of it was not something that we had implemented yet. That was something that was just passed and wasn't set to be implemented until this federal fiscal year in October. So that is not something that we had accounted for in prior projections, though it would have allowed individuals to increase their shelter deduction, as I just noted. But for the Heat and Eat piece of it, they have restricted those Heat and Eat payments to only those households that have a elderly or disabled member, where previously it could be any SNAP household applying. So obviously what we will then see with this is that we will have a reduction in those households that are eligible for the Heat and Eat benefit, and as a result, a reduction in the amount of benefits that they're eligible to receive.
Thank you. Representative Hughes, followed by Senator Lesser. Thank you, Madam Chair, and I believe my colleague over here also has questions. First of all, I'm so grateful that we have such detail researching, entities on our behalf of DSS to do this preliminary analysis, which is unbelievably cruel to our constituents in Connecticut. We talked about Husky D and Husky C and Husky. Will students lose access to free school meals as a result of these cuts, and who is tracking that?
So the National School Lunch Program, which provides the free meals for children in schools, is administered by the Department of Education. What we do in our program is we have something called direct certification. What that means is households who are receiving SNAP benefits, TANF benefits, or Husky A benefits with
Husky A,
an
yeah.
income of 185 or less would be eligible for free meals. So any reduction in SNAP households or any of those other categories for households with small children would then receive, or would no longer be able to receive, direct certification for school meals, though they would still be able to apply for the National School Lunch Program through the school itself. And if their income allows them to be under the 185%, they could still receive it, but it becomes kind of an administrative burden upon the household to have to apply, where previously they were automatically enrolled by virtue of receiving one of our programs.
Right, and we would have to communicate that, right? And can we do an analysis of that cost of those dropping, or is that not under DSS's capacity?
I think that would be more on our partners at the Department of Education, as they ultimately identify which program allows the child to receive the National School Lunch Program meals. So they would be best positioned to be able to identify the potential drop.
Okay, I'm very interested in this committee getting a money level analysis of these costs, if we need to backfill them, if we need to partner with other states to backfill, to, keep our people fed. The other question I have, can we go to that slide about the retroactive down to 1 month? Can we go back to that slide with, I believe it was Husky D enrollees from, was that slide 11? Okay. So as we're looking for that, we're talking about the administrative burden on, is this people who coming out of the hospital to nursing homes or rehab? Is that what we're talking about?
It could impact those members, yes.
Right. Which currently the only way they're getting into nursing homes or home care, does it impact our home care that we are presumptive eligibility for home care coming out of a hospital?
I mean, the way I would answer that, Refuse, is it would impact everybody.
Everybody.
And to the extent that those levels of care or services rely on that 90-day window.
Exactly. That's what I'm
Yeah,
talking about.
yes.
There's no way that they're going to be able to determine eligibility with somebody super sick coming out of hospitalization in 30 days. I mean, it's just administratively impossible. So where are those folks going to go?
So we, again, I think we probably should have started by saying we're doing everything we can to reduce harm to all of these people. So we will do everything we can to speed that process up, the eligibility process. But I think you're right in saying that, that's a vulnerability. So I think you're correct in identifying that as a vulnerability. But again,
It seems
goal-
deliberately cruel to the people that are most least able to actually do their own eligibility determination.
Yeah.
And who may not have family members to do that for them at home or spouses. And therefore, I think that we would go back to an incredibly costly going directly into nursing home when it's much more cost effective to go into presumptive eligibility home care following a medical crisis.
Yeah.
And that burden would then come back to the state.
Yeah, I just think I want to emphasize again that I'm saying this as maybe as an opportunity, which we don't use that word that much in this discussion, but to the degree that we can improve, upgrade our technology and to advance eligibility verification, we are trying to do that. So, and I'm agreeing with you that that's a vulnerability, but I'm also just want to say we're doing everything we can to make sure that we can, yeah.
Oh, I'm
Okay,
not,
I just want
I'm
to
not
make sure that
holding
we're.
you accountable to an impossible standard. I am not. I am just super concerned about the actual
That's fair.
impact on future fragile folks, coming out of hospitalization, especially, and the workforce that will not get paid. So, thank you. Thank you, Representative Hughes. Senator Lesser had asked a rhetorical question, so we're going to give him one more shot, and then Representative Dathan and Representative Fortier.
Thank you. I realized I was lobbying against my own interests there. So I want to just follow up on actually Representative Hughes's question. We've heard, a lot of different cuts to different areas, a lot of new paperwork and administrative requirements. On the SNAP side, they're just straight out cost shifts to the states. They're just dumping, the president and his allies in Congress are just playing a game of sleight of hand where they're hiding costs and shifting them to us in the largest unfunded mandate I've ever heard of. But what we're not hearing from the two of you, and I hope we can, is a number of dollars. One, I saw immediately after passage of the Republican budget bill, there was an analysis from the Kaiser Family Foundation that suggested that on the Medicaid side alone, Connecticut was likely to see a $13 billion cut over the over the decade. And I haven't seen in the numbers that we got out of OPM or out of DSS specific dollar figures for the size of the cuts to the whole legislation and also in each year. So if we can go to our friends on the Appropriations Committee and make an ask. I'm also not hearing an ask on the administrative side, how many positions you need and how many dollars you need to make these IT upgrades that are so clearly needed. So I know that the answer that everyone I've asked, and we've had conversations in private and public before, is, well, we're still figuring it out. But we also are moving towards a potential special session. And we also know that there need to be major decisions going forward. So just in terms of what DSS needs on both Medicaid and SNAP immediately to start the process on both the infrastructure, but then also looking toward, between now and the end of the next fiscal year, what do we need to do to start making those changes? And I see some, oh. Hi, sir. Are you with DSS as well?
I'm on loan today just for the Human Services Committee, if it's okay. Senator Lesser,
I think I've met you before, but could you just introduce yourself for the
Thank
benefit
you.
of the assembled multitude?
yes, Claudio Gualtieri, Senior Policy Advisor, Head of the HHS Division of OPM. Glad to be here. Thought I would accompany my friends at DSS, given that the subject of today's conversation is about the OPM transmitted letter and at least the initial determination of impact of some of our human services programs, Medicaid and SNAP being the focus today. So I just want to take a few points to say, with respect to the retroactivity, we have two different sets of criteria. A 2-month, we're allowed to go back 2 months for certain groups, including the Husky C. Those are likely to be the ones most commonly in a nursing home or needing long-term care assistance. And then the 1 month is obviously a lot tighter. So we've been working with DSS to at least quantify the analysis of how often is it the case that we go back the full 3 months, and what does that look like? I think that's an important data point before we can sort of build out the process and system to cure for that. The second thing about building out the infrastructure for PS and IT, I think there's a couple key inflection points that we're waiting for. One being, there has been signals from the federal level that they want to build out a common set of infrastructure and use some of the federal implementation dollars to do that collectively. To the extent that happens and allows,
I got to jump in there, right? So the Attorney General of Connecticut is currently suing the federal government over IT data security. And you're suggesting that we want to trust the federal government that we're suing over data security with more data?
no, I think what I'm suggesting is first we should see, one, what the rules are. Medicaid work rules requirements don't even effectuate and aren't going to be issued until June of 26. So we need to understand the rules before we can master the rules. Then, to the extent that there's common opportunities with peer states to do some collective sharing, where the infrastructure build is not duplicated here in Connecticut, but maybe we could do something regional with New York and Massachusetts, that may be an economy of scales that we want to pursue. So appreciate your opportunity to clarify that point. On SDE, I wanted to go back to Representative Hughes. Our initial assessment in coordination with SDE is that there will be no impact to school lunches for this school year. So we're taking inventory about any potential impact in the future, but in the short term, for the current calendar year, we've received assurances that there's no OBA HR1 impact on that. The last thing I'll just say in terms of presumptive eligibility, because a lot of people on this committee, along with the aging committee, were instrumental at creating a presumptive eligibility. One of the good things about Connecticut is, in addition to the federal waivers, we have a state-funded program. So it's still a flexibility that we have to initiate and use presumptive eligibility for the state-funded category of the home care program, which will provide that stabilization pending future eligibility determinations for the full Medicaid waiver services.
Okay, I appreciate your enthusiasm for jumping in there, Mr. Galtieri. But just if I could turn back to DSS, because I asked a specific question about the impact, the dollar impact on the Department of Social Services, and I'm hoping we can get an answer to those two questions, both the magnitude of the cuts and the investments that you need to start, immediately to start looking at PS and then your operating, your capital costs for IT.
Senator, we don't have those this morning, but we are definitely tracking those numbers and trying to really come up with a tighter range. As Claudio said, there's many factors in play. For example, the systems upgrade, the IT, there's numbers out there that maybe 100,000 people will lose eligibility in the expansion population Husky D. Well, if the system upgrades and if we have maybe a one directional feed from the federal government and can use that, maybe that's a lower number. Maybe it's 50,000 people. And that difference really impacts our numbers significantly. So we're just trying to tighten the ranges right now in terms of how many people we think may lose eligibility, and then what's the downstream impact to the budget based on that, as one example related to work requirements. But to your point, we are working each one of these, we're trying to put a number to.
But at this point, you have no, even though you've already kicked people off, right? By your own presentation, there are folks who have I can go down the list of your own deadlines that you just presented in your presentation, but there are folks who already lost eligibility on passage. So
You mean on SNAP?
on the SNAP side, yes. For example,
Do we have
on the SNAP
numbers on
side, there was
Yeah.
right there.
Senator, if I could clarify that, what we noted is that as a result of the bill, it had an effective date of upon passage. However, we have been informed by our federal partners to not implement the changes until they were able to provide guidance to us on how to effectuate it. So for example, if you have individuals that are non-citizens that are currently receiving, we needed clarification as to whether or not we had to remove coverage immediately or if we did it upon their next recertification. So that was something that we needed from them before we could move on that. We to date have not received any of that information from our federal partners, so we have not effectuated any of the changes or reduced eligibility for any of our populations at this point.
Okay, I'm just, we need to do stuff. And if the idea is we're just going to sit around and wait for the federal government to figure things out, I think we're going to miss the boat. So if we're, we need to give you the tools to start developing systems. I understand that there are questions out there, and there are, I'm sure, an infinite number of questions that the federal government in its wisdom has not answered. Maybe I'm looking around, and this is an issue that all 50 states are struggling with. I just got back from a conference that some of my colleagues were at, where we were with red states and blue states all struggling with this. It is hard not to notice that this side of the room is empty. And I don't know if it's only the job of Democrats to figure out what the intention of the Republican budget bill is, but we need to figure this out. And we can't just sit there and say, hey, we need more time, we need more time, we need more time. We need to start making decisions and making investments in DSS so that these programs that our citizens rely on are there. And if they're not, then we're not really able to serve them. So I don't know when you can get us those numbers. I had hoped we would get those in the OPM document that we got weeks ago. We didn't get them there. You don't have them here today. So when are we going to be able to make a decision about additional investments in DSS?
Senator, I will take that back and we'll get an answer. I just want to make sure that you know that we are not sitting around. We are kind of pressure testing every single one of our assumptions on every single one of these, and we are trying to refine those numbers.
Thank you.
The other thing, Senator, if I can add, this is Claudio again from OPM. I think that there's going to be another piece of the puzzle here that we need to be mindful of, and that's happening October 1 with potentially the federal government closing down and a continuing resolution or a new federal appropriations package. So I think part of this is taking a holistic look at what happened from the policy changes in HR1. How do those roll into the discretionary spending and a potential government shutdown? And how do we, in a best way, holistically look at mitigating the harm for FY26 for our residents? So there's more to come. We're mindful that another piece of the puzzle will happen in the next few weeks here. Hopefully, some of the worst maybe could get mitigated, including what wasn't done in HR1, which is continuing really important Inflation Reduction Act subsidies for people on the exchange. So we're hopeful still. The appropriations process is one that has typically been bipartisan at the federal level, and perhaps there's some leverage there to see if some of the worst that we're anticipating and planning for could get mitigated. But that's another piece, and we'll be likely coming back to you after October 1 with more.
Thank you. Representative Dathan, followed by Representative Fortier, followed by Senator Anwar.
Thank you so much, Madam Chair. And I think the good co-chair on the Senate side started asking my question, so I appreciate that. I currently have 6 questions that I'd love to ask. I recognize that we only have a few hours for this hearing, so I would hope that the agency would be open for us to communicate in a letter what doesn't get covered today. I'm really know that you guys work so hard and trying to do this, and this must be so frustrating because you are paramount in ensuring the citizens of our state have access to health care. And this is really bill takes away from so many folks. I know that you guys do redetermination every year for SNAP and for Medicaid. And I'm hoping that within our current system, we would be able to quantify our current population for SNAP. And in slide 4, you kind of highlight some of the people that may be at risk for losing it. And I think to understand how many people are in the age group of 19 to 64? How many adults have children in their care under the age of 14? How many homeless vets do we have in our state that are receiving this? How many people or how many communities in our state experience unemployment greater than 10%? Also, to understand the non-citizen limitations. And then in slide 6, we talk, and we need to know that for quantities, numbers of individuals, but also dollars that are allocated to those sort of programs. In slide 6, we talk about the SNAP Ed program. I know that, as the senator mentioned, the effective date is immediately. How much do we have in carry forward dollars to be able to cover that in our current budget? Because my understanding is there isn't a lot of dollars there in carry forward. And as my good colleague to my right said, that we have, children who are not going to be able to receive school lunches. And we all know if you don't have a meal as a child, it is really hard to learn. I know in my subcommittee, we are going in care management. We're going to kind of delve into the work requirements and then the systems that do that. But I'm also concerned with that we have community engagement requirements that could cover some of the work requirements as well as the higher ed. Are we going to be asking our nonprofits for proof of who is volunteering in those organizations? I mean, our nonprofits are already so stretched the way they are. And I get concerned that this is going to be another thing. So I do want to talk about that in the care management committee. We talked, I remember in MAPOC, we've talked about redetermination and how much of an overhead that is for the agency. To be doing that every 6 months in our current system is going to be a challenge. And I think we had talked about this before, that there were hundreds of people that are involved in that process. So does that mean we're going to have to double that workforce? Is there ability to put people on a scale that we don't have to do everyone on January 1st? Is there ability to break up the population? So I'd love to know, if that's going to be an option. And I know some of these things are still getting worked on. On slide 10, you talk about the undocumented folks. And I don't have a full understanding. I mean, you had said that, people are going to be held harmless. I look at slide 10 and I look at what you say here. I don't think that people are going to be held harmless for either SNAP or Medicaid changes as a result of this. And how much, and I know we do not get a federal match on those dollars currently, but really what the numbers are, and to understand, are we risk of losing other federal dollars because of this policy? Because it is so important that everyone in our state does have access. We also talk about cost sharing in slide, I think it was, yes, slide 12. We have $35 per service on Husky D. Now, just for the avoidance of doubt, these are low income adults that are between 19 and 64 that may have a very low income. And so now we're asking them to pay a cost sharing. How much is that going to affect people's way of life? And are people going to not go to the doctor as a result of having to pay $35 for a non-well visit? What happens to those dollars, those $35? Are they going to the providers? Are they coming to the state? Who's going to be collecting those dollars? How is that kind of process going to be managed? But I've gone on, but those are the sort of things that I think you all are definitely looking at. I'm not saying that you're not, and I know OPM and Claudio, the undersecretary, has been thinking about all these things as well. And I do think we're going to have further conversations to kind of quantify this, because I don't feel right now that we have a handle on that. So thank you, Madam Chair. And if there's any
just respond?
information you have, I'd appreciate it.
We'll certainly take those back, but we can also update that last slide. That's not to exceed $35 for the cost sharing. The cost sharing can actually be quite low if the state chooses to make it exceedingly low as
So
well.
you could make it like a penny.
I forget the threshold, but I will get back to you. It's
And where do
it's
those
low.
dollars go?
So
Um,
yes.
Are they going to affect the Medicaid rates that our
Right.
primary and other providers get, specialty
Yep.
care providers?
But we can put the minimum in.
Yeah, and I just, again, talking about looking at quantifying the services that we currently offer for the cost sharing. I mean, how many services do we provide in our state that might be subject to such a cost sharing? We have exempt services here, but I think of, elderly folks who might need cataract surgery, or people who have broken legs, or other sort of services that they need. It doesn't talk about, giving birth and all of those things that, complications that might come up in the maternity side. I mean, I could go on and on and on. And I know I'm speaking to the choir here. And I, again, appreciate all your work. I just have so many concerns right now, and really need to get a better understanding of how we're slicing and dicing the data to get a real handle on the quantification of this, because I see huge impacts to our fiscal 26 budget based on this. And I don't want the citizens of our state to lose out, and the residents to lose out on any sort of care. So thank you.
Thank you, Representative. Representative Fortier, followed by Senator Anwar, followed by Representative Shake.
Thank you, Madam Chair, and thank you to all the DSS folks and our OPM friend. I appreciate my colleagues addressing the numbers and trying to get a handle on the financial impact of this, but my questions are a little bit different. In terms of the expansion of the requirement for work to age 64, the exemptions that we have will carry forward. And there are certain people that are exempt that I would call profoundly disabled. For instance, I have a brother and sister that are both in long-term care, one in a group home and one in a nursing home. They are qualified as disabled through Social Security. They've been that way for years and years. And they're both actually under 64. But the point being, I'm wondering about folks that are less profoundly disabled that might become disabled in that time frame from age 54 to 64. For instance, they've been working their whole lives and they had a hip replacement surgery and it didn't go well, and they have a relatively physical job, and so they're going to stop working before age 65 and perhaps need Medicaid. How do we currently determine those exemptions for medically frail or disabled? And what does that new population between age 54 and 64 have to provide? If my question is making sense.
Yes, thank you for the question. Just to clarify, there's two different work requirements or community engagements that you're speaking of here. So in the SNAP program is the increase of the individuals from 54 to 64. In the Medicaid program, it would be a new, obviously, work requirement of community engagement for that population of individuals. So in the Medicaid program, they're currently not having to provide anything, obviously, because we do not have work requirements within the program. future state, they will have to provide it if we're unable to determine it through, as Director Halsey mentioned, our interfaces with other agencies such as Social Security that would identify if the individual is receiving disability payments or SSI. That is currently the practice within the SNAP program. We do have a direct interface with Social Security to identify those individuals once they begin receiving Social Security, disability, or SSI. However, the population I believe you're speaking to are those individuals that are in the in-between. We do have processes in place that we are able to determine an individual's ability or inability to work. It may require that they provide to us a doctor's note or some other records that show that they have this disability preventing them from working. But I believe it gets to the question of, or to the piece of the administrative burden that we were speaking of earlier, that it will mean that these individuals who previously did not have to provide this information will now be required to show us, for lack of a better terms, that they are no longer able to work, even though they perhaps had been working for many years.
Okay, and I want to follow up with something I heard. I was listening to the radio and heard a story where some cancer providers were talking about their concerns about this bill. In, again, the situation where working people develop cancer and are now going through chemo or radiation, and it's weakening their body to the point that they can't work. And those folks often go on Medicaid in that situation. Again, do you think this is going to impact them because they may be considered healthy enough to work even though the chemo is exhausting them temporarily?
I think under the new rules, at least for Medicaid and the work requirement exemptions, I'm hoping that we would get guidance from CMS that somebody would be able to provide us documentation that they meet the medically frail definition based on this scenario that you just gave us.
Okay, I'm just concerned because those doctors were concerned, and I think perhaps they didn't see clear definition in the bill that would allow those folks to, go that route during cancer treatment.
You have an excellent question, so I just wanted to piggyback on it to illuminate on a couple things. One is we're still waiting additional guidance on the hardship exemption, that the states are going to have some flexibility in how they scope that, and certainly the scenario that you played out is one of those hardships that in Connecticut we was try to use every tool in our arsenal to make sure that that individual is exempt. The second thing is you're bringing up a really interesting point, and one that's going to have financial consequences, but may not necessarily have a loss of eligibility consequence. And that is that if someone is on Husky D, but has a disability, a physical disability, or a serious illness that may qualify them for Husky C, we may have to figure out a pathway to seamlessly move someone into Husky C, avoiding the eligibility for work requirements and all that. That will result in a change in our FMAP, because Husky C is only at 50%, as opposed to expansion being 90%. So it's a cost shift to the state, one that would be assumed under current services, but not necessarily a harm to the individual. We're just going to have to figure out how to seamlessly work those subgroups of Husky to make sure where that's an appropriate shift that happens, even if there is a small FMAP loss or a significant FMAP loss in that case.
I think Claudio just talked about another layer of budgeting complexity, right? If we're going to lose X number of people in the expansion population due to work requirements, what percent are going to come over into a new eligibility category? So they're good on medical services, but we're missing out on the enhanced match. And so layering that into all of the budgeting.
Thank you. Thank you.
Thank you.
Senator Anwar, followed by Representative Sheikh, followed by Representative Meskers.
Thank you so much, Madam Chair. First, I wanted to thank DSS for the work that you're doing at this time in this manufactured federal government crisis that is going to impact thousands of people in our state. And I'm not sure what they're trying to fix, but it's not fixing anything based on what we are hearing. And I share the concerns that many of my colleagues have brought forward. My specific question is that as I'm reading the HR1, there is a little bit of a confusion about the ACA opportunity. If somebody is ineligible for Medicaid, even the ACA opportunity is gone for them. Is there, and it's not across the board. Do you have a better understanding of that option, and how do we clarify that? Is this worthy to put a chart together to see who will be able to potentially find resources to buy affordable care?
Senator Anwar, are you speaking if somebody loses eligibility because they don't qualify due to work requirements, they've now also, they're not eligible for the exchange?
Correct.
Yeah.
And that would be a disaster if let's say they were able to get families or others to help out to get them some help through the exchange. I guess it appears that even that option is not available to them.
You are correct, Senator Anwar. So I think this is Claudio. Sorry, if you're joining virtually.
Yeah.
Yeah, section 7.
Yeah.
1119, I think you're referring to, and it does prohibit advanced premium tax credits or cost share reductions for anyone who is going on the exchange as a result of being sort of essentially barred from Medicaid because they don't meet the community engagement component. So that is a consequence that if you get off of Medicaid, you don't have the immediate backstop of the exchange. Also with that, given that Covered Connecticut requires you to be eligible for the full subsidies, the APTCs, and the cost share reductions, Covered Connecticut is not an option either for those individuals. And that's something that we have to think through, because I think the commercial market is potentially the first most direct impact of what wasn't done and should have been done in HR1.
So this is, again, we're not saving any process. This is outright cruel. This is something that if the Medicaid savings are being looked at as a way to save, this is outright cruel activity. And I think um, this is, I don't know what the agenda is, but it's not a good agenda for the perspective of people. So thank you for this information.
Thank you, Senator. Representative Shake, followed by Representative Meskers.
Thank you. Good morning. So good morning. We have I think the sentiment is we're going to be here a long time today because we're asking really important questions and you're the first. So to everybody here, just try and hang in so we can get through this hearing, which is helpful. I echo all of the sentiment and concerns that my colleagues have raised to you. I think we're going to have to come back and have another follow-up meeting where we're able to actually review and then ask questions about that quantitative data, which is very important in the event that we are moving into that special session so that we can best do our jobs in advocating for the resources that various departments, state agencies are going to need in order to absorb the shock of HR1. I would like to ask about our veterans. So on slide 4, the current state versus the future state, it says it removes exemptions for veterans, those experiencing homelessness, those under 24 who are aged out of foster care at 18. Regarding our veterans, in anticipation of how this will impact Connecticut veterans, is there any communication right now with the Veterans Hospital or Connecticut Veterans Association? What are we doing as a state of Connecticut to anticipate what that specific impact is going to be, so that those that have served our country honorably and their family members also who receive benefits, but this specifically is explicitly saying for veterans, how are we going to continue to assist and support them? Are they then eligible to sign up through our state ACA? I mean, what are the pathways? Senator Anwar referenced potentially some type of flow chart. And I think in the list of vulnerable populations of how this bill is going to negatively impact so many different populations here in this state, that would be my request. It could be, in this case, we're talking about veterans, but foster children, those that are, the households that have 15, 16, 17-year-olds in their house. That's my first question, because I know you can't answer that right now. My second question, my background is healthcare. So when I'm hearing the concerns and how people are going to be reclassified or recoded, right? That first, second, third interaction of how medical professionals, whether it's doctors, APRNs, et cetera, it sounds like to me, correct me if I'm wrong, is how people are going to be coded in the system. Because if they have a serious illness versus an emergency versus, right, those are different medical codes that get put in. That then trickles down and affects our visiting nursing association or all these different organizations across Connecticut that help not just those that are transitioning out of the hospitals and then into their homes, which Connecticut has done a better job than other states, right? So that we don't have patients just sitting in hospitals all day so that they can have a better quality of life. Has DSS begun to think about what that would entail? Because it's not just DSS, it then filters down to impacting our Connecticut hospital associations, our long-term care facilities, outpatient rehab, AMBI, visiting nursing. My colleague mentioned maternity services. We have some, great programs where we have postpartum checkups, all of that as outpatient now. Those are some of the questions I have, where next time, if we have the opportunity to be able to talk about these things, if you're able to quantify those things and serious inquiries, because it's a ripple effect of how this is going to affect essentially all of our social services and healthcare systems across the state.
Could I just ask a clarifying question on the term coding? Do you mean if somebody perhaps moves from a Husky D, the expansion population, to a Husky A, what would potentially be the downstream impact related to healthcare services?
That could absolutely be one way of trying to answer the question. My original question was regarding, patients who are people who suddenly find themselves very ill or sick, and then they cannot go to work, and whether they utilize FMLA or a paid family medical leave system, but then in their course of recovery and healing, they might be deemed not be able to physically be able to go back and do their jobs. But in several constituents that I have and over years of advocating, and there's many people here in this room who understand what I mean, where those first interactions of where a patient is going to seek a provider to then figure out how they can be treated and what their rehab or time out of work is, whatever that is. The insurance companies, right, are very specific in looking at that person's medical history or their medical experience for that said disease or problem that they're dealing with. And then people can be denied or be granted accessibility for additional services or additional rehab. But in that medical coding of how that patient is being classified from the provider, from what the future state of eligibility requirements are, I think it was Mary had inquired about people who are in long-term care or if they're in outpatient rehab, whatever the case may be, people who suddenly find themselves with a cancer diagnosis, right? Or it's a car accident, and how those providers are coding them. Is this an emergency? And then it brings in the conversation that we have to have with the insurance companies, the health insurance companies, so that people are not losing their potential coverage or services or being kicked out of the system because of a potential clerical error, or pressure from insurance companies to not have coding, right? We want to make sure that people are taken care of. So that, like I said, it's a domino effect. It's a ripple effect of how this HR1 bill will impact multiple agencies, departments, people. But for our vulnerable population, you could be happy and healthy today, and tomorrow you have a sudden event and everything just changes. So when we come back, if that could be. Does that answer your question?
Thank you for clarification.
Thank you.
Wonderful. Thank you, Representative. Representative Meskers, followed by Representative Johnson.
Thank you, Madam Chair. I guess the first question I'm trying to grapple with is HR1 and the financial impact to the state. I've generally heard in terms of an 8 to 10% reduction or anticipated reduction in federal expenditures and impacting us. So it's probably helpful if we're trying to analyze the problem and addressing the problem is to look at the timeline, because it looks like implementation is staggered. So is that a smoothed assessment of 8 to 10%? Or are we anticipating a 3, 4, or 5% in the first year and larger amounts in outer years? How should we address the anticipation of the implementation? That's my first question.
I'm hesitant to give you a total aggregate percent decrease at this point. But to your other point, I think it would be fair to try to kind of compartmentalize those projections by fiscal year. I think that's a good exercise that we could do.
Yes, and just to add, Representative Meskers, is that it is the case that this document, the HR1, was staged in a way with some of the political realities in mind, right? So you're going to see a lot of the more aggressive changes, Medicaid redesign, work eligibility, some of the changes that are happening that are fundamental to SNAP happening later on and lighter touch in the beginning. So we're seeing a lot of the upfront the gives in the bill, the things that are nice to tout, some of the tax cuts, some of the tax relief front loaded, and some of the more painful program changes towards the end of the eligibility period, the 10-year window. But yes, we can certainly do that. We've sort of tried to outline at least a timeline. I think your recommendation on making sure that we're taking this incrementally and dealing with the most immediate needs by fiscal year in the state is a prudent one. It reminds me of what the secretary always tells us since HR1 passed, is that we got to chop the pile of wood immediately in front of us first and then move forward. So point well taken.
And the second thought is that if it's a staggered implementation and the cuts are 2, 3, 4%, whatever the cuts are in the first 2 years, et cetera, or less or more, for us on a policy basis, it's going to be very important to figure out who the targeted classes are that are going to be impacted and how they're going to be impacted and what is our strategic response to that. Some of the vulnerable populations, we may find it completely unacceptable to deal or accept those cuts. Some of them may be unpalatable but acceptable. So how we look forward is, we basically have about a third of our population, as I understand it, on Medicaid and the programs. So what percentages of those populations with redetermination, et cetera, are exposed and when they're exposed? So we can start working on the policy basis of when we expect the problems to hit, that people are either kicked out of the provision. And lastly, if I beg the permission of the chair on the 2 limit, we're looking at this from the state side and the impacts on the state. I think it's very important to understand what the implications are for the hospital system. I mean, I expect that to come from them as well, but the potential for cost shifting, and I'm kind of putting on my role in the insurance committee, of potential cost shifts if we have under-reimbursed care in our emergency rooms and the impact on our hospital system. So that's a, that's one we don't normally quantify is the non-fiscal impact to the state. And I'm thinking of the fiscal impact to the private sector, particularly the insurance, the hospitals, and unreimbursed care. So those would be kinds of things that would help us when we start to think about policy. That's all my comments. Thank you, Madam Chair.
Thank you, Representative. I'll respond and just to say, I think that you're right. I think when we're trying to approach this, we're trying to look at the triple bottom line and how can we make the most impact. So in the short term, I think to solve three problems, we need to make sure we keep our insurance rate low, our insurance coverage rate high. That will make sure that the private providers and hospitals and healthcare practitioners can actually bill for their services and avoid some of that uncompensated care. It's also going to have that important effect of making sure that our health insurance exchange stays healthy and vibrant. What we don't want is adverse selection in the exchange. Then what happens is costs skyrocket for everyone else. You only have the sickest population getting health care, tons of uncompensated care, and a destabilizing network. So I think in the short term, our focus is making sure that we in Connecticut try to keep people covered, keep coverage rates high. We're lucky. Unlike a lot of states, a few years ago, again, with the leadership of a lot of people on this committee, we initiated Covered Connecticut, which is a waiver program that wraps around the qualified health program plans on the exchange, provides 100% zero deductible, zero copay, zero premium health insurance for all those up to 175 of the federal poverty line. That's almost 50,000 people, about a third of our individual market. It's going to be shielded from some of the worst of the attacks because of the Covered Connecticut program. So we're going to look to build and reinforce on some of those initiatives.
Great, thank you. Representative Johnson.
Hello? Did you call on me, Madam Chair?
Yes, I did. Go right ahead.
Thank you so much. I have a question that might, you take a peek at this, and maybe it's something we could discuss more in the complex care subcommittee. But as listening to the changes in the retro, eligibility going from 90 days to 30 days, it made me think about the people who are in a hospital setting and needing to be discharged into a safe environment. Now, the certification for reimbursement in hospital settings is that when the discharge plan occurs, they have to be placed in a safe setting. If in fact the reimbursement rate for people in that circumstance, only has 30 determination, then it could be where people will in the hospital waiting to have an eligibility determination before they can get transferred into either a nursing home or into a home care situation. Because they won't know, the agencies will not know whether or not the person's going to be eligible for Medicaid, and they won't be getting paid. I'm just going to go in for Medicaid services, for example. From say a hospital coverage for a Medicare beneficiary to some Medicare coverage either in the home care setting or in a skilled nursing facility setting. So I'm curious about whether or not we will be able to continue to look at the how the hospitals are managing the discharge plan now and how they will manage discharge planning when we're down to only 30 days to make a decision about whether or not somebody is going to be for the Medicaid program. And then the follow-up would be on that analysis. Will this have an impact on the certifications that the hospitals have lose money when they're audited by the federal government? So I don't expect an answer right now, but I think it's one thing that we want to look at when we look at the transition from 90 days to figure out if a person has eligibility for Medicaid to 30 days. There may be some hesitation by the providers that do provide home care services or skilled nursing facility care services to accept somebody unless they have some way of knowing that they have to pay for services that may not be covered either by Medicare or Medicaid. And so thanks so much for your work. Appreciate it.
Great. Thank you so much. We will follow up as a committee with a letter with the additional questions and the questions that were asked and not addressed today. Thank you so much for being here. We are obviously at 11:23. This is an incredibly important conversation that will continue, but we are hoping to be able to get through folks today. So if you could please, not to put stuff on Brianne, but if you could please go up to the clerk if you are on the list of presentations and have a hard deadline, that would be very helpful because right now we are going to jump to the potential public impact and hear from Suzanne Garaffa and Marianne Langton because they do have transportation at noon. Thank you so much for being here. Yes, go right ahead. Thank you.
Here with Mary, like, I'm over here with Suzanne for 2 I'm gonna have Maureen read me because I have trouble reading, okay? Thanks.
Thank you.
Thank you, Senator Lester, Representative Gilchrist, and the members of the committee. My name is Suzanne Garaffa. I live in West Hartford. When I moved to Connecticut in 1987 as a disabled person, it was a very difficult process to get the support services that I needed. I had to ask for food stamps, and they gave me $10 a month, which felt very degrading to me. But it's 38 years later, and I'm only receiving $23 a month, and I find this insulting. There's a perception in society that people who use food stamps or the SNAP program are lazy and use the money to buy steaks and sodas. This is not me. I've worked and even started my own company, Graphic Computer Graphics. Even now, I work when I can and I volunteer for many advocacy groups. I've fought for medical accessibility and wheelchair repair reform. I started Suzanne Fights for Change to support disabled people who are in need of assistance. I am not someone who sits around and does nothing. And no, I do not use my $23 to buy steaks and sodas. Groceries are expensive. I use the money to buy milk and eggs, and I'm under a very tight budget to buy the rest of the food I need for the month. Can you live off $23 a month? Can anyone live off $23 a month? Is this acceptable?
No.
So, I worry about losing this very little amount of money that I receive. Instead of talking about restrictions to the SNAP program, we should be talking about increasing the minimum limits, especially for families and disabled people and other vulnerable communities who have so many other expenses to worry about. Trump is trying to take away our basic rights, and we should not let him do this.
This is my feeling and my feeling alone. This needs to stop now. You guys need to stop it because I'm sorry, guys. The Republicans aren't doing anything. I'm a Democrat. I'm proud to be a Democrat. So stick up for us and Republicans wake up.
Thank you very much, Suzanne. No, thank you. And thank you for sharing what the SNAP benefit looks like for folks. Thank you. Yeah, and thank you for coming. Good. Good morning.
Goodbye, the agenda. But
Marianne said, thank you for modifying the agenda for us.
My personal assistant, Patty, that's me, this is Marianne, will be reading the paper that I wrote about some Medicaid programs that are very important to my life. For many years after graduating from Southern Connecticut State University, I was only able to utilize Medicaid for my health insurance. Insurance companies disqualified me from obtaining regular insurance from my various jobs because of my pre-existing condition, cerebral palsy, and from having allergies. 20 years later, when I worked for the Connecticut Council on Developmental Disabilities, I was finally able to obtain health insurance from my employer despite my pre-existing condition. Yet, Medicaid is vitally important to me because I am on the Medicaid Personal Assistance Waiver, now called Community First Choice. This waiver allows me to hire and manage my personal assistants who support me with my personal needs at various times of the day. This waiver has enabled me to move from my parents' house and to live independently in my community. Now, I am fearful of the ramifications of cuts to Medicaid. I fear that there will not be funding for my personal care needs, which allow me to live independently in my own community. I would be forced to move into a nursing home because that will be my only alternative. The taxpayer cost of living in a nursing home is much more than the cost of providing supports and services within the community. In addition, Marianne said, and Jillian would agree, no nursing homes would want my big mouth.
I think they'd find you entertaining.
In addition, Medicaid pays for my durable medical equipment. I need a new power wheelchair every 7 to 10 years because their lifespan is only 10 years. In addition, I require a power wheelchair with custom seating and adaptations because I sit in my wheelchair for at least 15 hours a day. These adaptations permit me to tilt, recline, and be comfortable in my chair throughout the day. 5 years ago, my power wheelchair cost $45,000. I could never afford these costs without Medicaid. Power wheelchairs allow me to be a productive citizen. In conclusion, Medicaid is a vital program for me and many other people. Please assist me in remaining in the community where I am a productive and tax-paying citizen. Thank you. Thank you.
Thank you so much. Thank you for being here and really in shedding light on what this impact will mean. Representative Hughes does have a question before you head out.
Don't leave yet. Marianne, you have so eloquently described your life at home with community-based PCA services. Do you have an estimation of the cost of those services? Because we just did a rough estimate of the cost of living in a nursing home instead. Do you know how much a year?
I believe it comes a year. I believe it costs $9,000 a year.
And living in a nursing home would cost $185,000 a year. So any diminishment of that kicks you back into a nursing home is a tremendous cost beyond loss of independence and loss of agency and loss of tax-paying independent, economic agency over your own life. But I just wanted to highlight that about.
Thank you. Thank you. No.
I'd also say, and what a loss to the community.
What a
'cause
loss
we love
to-
having you around.
And what a loss to the advocacy of self-determination.
Thank you so much for being here. Now we're going to jump to the presentation from Access Health Connecticut, James Michelle, my apologies.
Okay, good morning, all. I'm James Michelle, the Chief Executive Officer of Access Health Connecticut. Thank you, Senator Lesser and Representative Gilchrist, and to all of the committee members for the invitation to participate in today's Human Services Committee meeting. There are many federal changes impacting Connecticut residents and their health coverage on the exchange. I'm here this morning to share the 2026 impact of HR1 and Connecticut residents who purchase health insurance in the exchange. I will also address another important federal change that the impact from the likely expiration of enhanced premium tax credits. Those enhanced subsidies are set to expire on December 31st, 2025. Let's begin with some specific topics we were asked to prepare for this morning. First, we will address some details about the lawfully present immigrants with household incomes less than 100% of the federal poverty level who will be impacted as a result of HR1. Lawfully present immigrants who are not eligible for Medicaid due to immigration status with income less than $100,000, 100% of the federal poverty level will no longer be eligible for premium tax credits. As of Friday, August 29th, there were 5,336 Connecticut residents affected by this change. Communities within Bridgeport, Stamford, and Waterbury will be most affected. About 25% of these Connecticut residents live in those three cities alone. Based on our current enrollment data, using plan year 2025 premium rates and the enhanced subsidy calculation table, it would cost the state of Connecticut $62,837,329 to continue to provide advanced premium tax credits for this group of individuals. The real cost will be higher given the rate increases requested for plan year 2026. Access Health Connecticut is committed to supporting this population. We'll be conducting outreach to help them understand the changes. We have prepared an action plan. The Access Health Connecticut Health Equity and Outreach Team is planning a community-first, data-driven approach to help Connecticut residents. We have added 4 new mobile enrollment specialists to the team to help provide free in-person enrollment assistance. They are fully trained and ready to go. We increased our navigator presence this year, activating trusted resources within the communities. The community resource also include the community health centers that will likely play a much more critical role in the lives and health of our neighbors across the state of Connecticut next year. It should be noted that we have navigator assistants in all the major cities most impacted by these changes, especially Bridgeport, Stamford, and Waterbury. And we will continue our enrollment fairs throughout open enrollment to help eligible residents find coverage. The marketing team is focused on communicating the changes to customers and opportunities to find coverage that would best fit them and their families. A robust mail, email, and text campaign is planned. There will also be a mass media open enrollment advertising campaign targeting eligible Connecticut residents. Now, let's shift to another federal change from HR1 affecting Connecticut residents. The One Big Beautiful Act eliminates the repayment caps for excess advanced premium tax credits amount starting next year. Since the beginning of the marketplace coverage in 2014, lower-income consumers had some protection in place to cap the amount of excess premium tax credit the consumer was required to pay to the Internal Revenue Services when filing their return for the tax year. But these consumer protections are going away as a result of the bill. Starting for tax year 2026, no matter what their income is, any customer who receives excess tax credit amounts will be responsible for paying the entire excess amount back. This repayment will need to be paid to the Internal Revenue Services when filing a return in 2027 for plan year 2026 premium tax credit amounts. We do not have data on consumers who have received excess premium tax credits in the past. For the current enrollment population, we estimate there are roughly about 108,000 individuals who could be impacted by the federal changes. This includes those receiving premium tax credit assistance with income below 400% of the federal poverty level, which is the current income limit for the repayment caps. This number excludes the roughly 5,300 individuals who may no longer be eligible for premium assistance in 2026. Access Health Connecticut will ensure that everyone is aware of the impact of the changes, including brokers, certified application counselors, and our community partners across the state of Connecticut. We will inform all enrollees of the 2026 tax year implication for the 2027 filing year, stressing the importance to make sure consumers accurately estimate their annual income and update it during the year if it changes. Communication here is key, ensuring that all stakeholders understand the need to update income throughout the year will be critical. We are currently exploring ways to simplify the process of reporting on income change and make it easier on our website if possible. And lastly, as I mentioned earlier, there's another big federal change that will have significant financial impact next year. The enhanced premium tax credits were first introduced by the American Rescue Plan Act and extended through the Inflation Reduction Act. It's possible that the federal government may work to extend them before they expire. However, currently there's no indication that that's happening. We have prepared some detailed information to help you understand the impact to specific populations in Connecticut. Please note that data we are sharing is calculated using 2025 premium and eligibility rules. If those enhanced premium tax credits are not extended, more than 142,000 customers currently enrolled will receive less financial help, and some will no longer receive any financial help at all. Approximately 28,000 Connecticut residents who have income over 400% of the federal poverty level will lose all their financial help. That's nearly 20% of the population currently receiving financial assistance. Let me put that into some perspective, into context rather. And if the enhanced subsidies are not extended past plan year 2025, Connecticut residents receiving financial help could expect to pay more than $3,600 a year for their health insurance on the exchange. And some families earning income over 400% of the federal poverty level will experience significant cost increase. For example, this is a real family living in Fairfield. Family of 5 currently pays $991 a month for their health insurance. And they receive federal financial assistance of $3,149 a month to cover the rest of the monthly premium. If they stay in the same plan next year with no rate increase, they could expect to pay $4,140 a month for their health insurance. That is a 317% increase over this year. We are hopeful that the federal government will act and extend these enhanced subsidies. But as I said earlier, right now, there's no indication that's happening. And back in February, I had authored an editorial that was placed in multiple newspapers across the state of Connecticut, where I spoke exactly what would happen if the enhanced subsidies are not extended. Madam Chair and Mr. Chair, I will pause now for any questions.
Great. Thank you so much. You mentioned having some information to share with us. Will you be able to email that over to our committee clerk?
Yeah, absolutely.
Wonderful. Thank you. Senator Lesser.
Thank you, Mr. Michel, for your presentation and for the work of Access Health. And a lot of the conversations about the Republican budget bill have been really focused on Medicaid and SNAP, but both the cuts within the bill for Access Health and also what's not in the bill, as you mentioned, there's no extension of the health insurance subsidies. is really going to devastate our small businesses out there, our middle class across the state. And I was struck by what you mentioned, which is a family in Fairfield with, I guess, an income of maybe $140,000 if you're at 400%.
Yeah, it's about $130,000 a year.
130,000, right? So people
Yes.
are doing okay, but not, certainly not wealthy by any stretch. A family of 5 people.
Again, Senator, yeah, family of 5, correct.
Family
2
of 5.
parents, yep, 3 kids.
3 kids. They would see their premium go from $900 something dollars a month to over $4,000 a month January 1st.
Correct.
Devastating, right? Nobody has $3,000 of extra income a month just sitting around able to pay for health insurance. This will be devastating for our small businesses and for our middle class. Just a question. So we heard earlier from the gentleman from the OPM that Connecticut's better positioned than other states because of our Covered Connecticut program. I guess I guess that may be true for it. I'm not sure the extent of the whether Covered Connecticut could address the population of folks who could lose coverage for the work requirements and the extent to which you see that as being a potential solution. And I also know that some of our sister states, I believe Rhode Island in particular, has said that, look, we don't know what Congress is going to do, right? There's a lot of, we've heard all morning, well, we've got to sit and tight and see what Congress is going to do, or what the federal government's going to do, or what kind of guidance we get from the feds. But we're looking at a cliff on January 1st where the residents of the state are going to see astronomically higher insurance premiums. So we got to do something. And so what I think Rhode Island did was really quite clever. And they said, look, the state will come up and say, we're going to make up the advanced premium tax credit difference if the federal government isn't there. Now, obviously, that is a huge fiscal impact to the state. So I didn't know if you had an idea of what the dollar impact might be, or if there's some way for us to finance it. But we just can't allow a family to go from, people are not going to be able to do it. We're going to see a huge number of people just go be uninsured because they're just not going to be able to afford their premiums. So what's the size of the dollars that the federal governments are going to impact? And do we have any sense of whether or not, Covered Connecticut could absorb some of that?
So, Senator Lesser, we have looked at those numbers and try to forecast exactly what the financial impact is that the state would have to absorb. We shared that. And actually, Senator, can I send that to you in the committee after this meeting? Because I have to go back and verify the numbers. But we have looked at the number. We have a fairly good idea if the enhanced subsidies go away, what the impact would be. But the number keeps shifting depending on enrollment in Covered Connecticut. Right now, Covered Connecticut is at almost 51,000. So we know of that population, 5336 will go away simply because of those who would not qualify. They are currently not eligible for Medicaid, but are in Covered Connecticut because of immigration status. So the number keeps shifting on a daily basis. So let me get an updated current number and send it to you and the entire committee.
Okay, and just also making sure that number includes the total value of the expiring tax credits that are for the population that you serve.
Sure will do, sir.
Okay, thank you very much.
Great, thank you, Senator. Representative Shake.
Thank you. Good morning. Piggybacking off of what Senator Lesser was alluding to, the sharp increase of cost for recipients that are in the program, and maybe OPM, you might, if you could come up, because you might have a little bit to contribute to this also, if you know the question, if you know the answer. We all have many concerns, and if there are 10,000, if there are a significant number of people who are now not going to be eligible for coverage because of HR1, and we talked about this with DSS, that sharp increase of what you just described of the cost to families going up to $4,000 a month, if we have less people in the exchange, that's just an estimate currently, correct me if I'm wrong, our gentleman from OPM, right? That's just an estimate now with people still in the system. So if we have, because it's a numbers game, it's a percentage, if we're not able to have people be qualified or approved to be recipients to sign up, then $4,000 might become $6,000. It's just, a number, right? But the ceiling is not necessarily $4,000 per household for that one example of I think it was a family of 5, right? And whether you're in Fairfield County, Stratford, the district I represent is Fairfield County, but we have I have a large number of constituents that do utilize the exchange. And another way that we talk about residents who are eligible are our ALICE families, our ALICE residents. So if there is a projection, a trend of what whether it's through Access Health and OPM, I don't know exactly how this works. I'm learning. But if there's a way so that if we are able to get back here again together and we have that quantitative data, so that we're looking at the numbers and the real impact, the potential impact, I would like to see that. And I know we don't have that answer right now, but when that does become available, depending on scenario A, we lose 20% of people who are no longer eligible. Scenario B is 30%, 40%. And what that cost means for the family or resident that's trying to access affordable health care, because it's no longer affordable, right? And that's not because of the state of Connecticut, that's because of the feds. Because then, again, a domino effect is how that's going to impact our hospitals, our care systems, because people will not have the ability to get their primary care, health issues taken care of, prevention, all of that. And we, again, I'm going to put on my nursing hat, we as people in the hospitals are absorbing, because we can't turn people away, and nor should we, but it's uncompensated care, and then that hits the hospitals. And I know they're going to be coming up here later, but just something, for, I'm sure all of us are conscientious of it, but whoever's out there listening, of how this truly is a negative snowball effect. And like I think I said before, we have to figure out how we're going to be bracing for impact, because we know it's coming. January 1 versus halfway through the year versus whatever they're going to do down in Washington by October 1, right, with the federal congressional budget and how that impacts us. But I have learned good ways, bad ways, but failing to prepare is preparing to fail, right? And no state in this country right now can afford to do that. So trying to prepare ourselves of what options we may have available. And if scenario A doesn't work, we have scenario B, C, D, E, where we all have to be working together. So I guess more of a comment rather than a question as I just worked through that. But if you have any feedback, either of you, I'd be happy to hear it.
Sure.
Yes.
Representative Drake.
Oh, sorry.
Very quickly,
James.
James can go
I'll
first.
talk.
Thank you.
Representative Drake, you are correct that the impact, these dramatic increase in rates, monthly rates, what that would drive the healthy purchase of insurance away. It's just not affordable for them. And those who need health insurance because they have a chronic illness, they will stay on. So then you have a pool of very sick people using our medical system to manage their health. But you have less money coming into it because the population buying insurance would shrink. So over time, that drives up costs for everybody. That's what the data have shown over the last 20, 30, 40, 50 years. So you have mostly people staying and the smaller population paying premium into a pool to pay claims. And then the healthy people do not buy health insurance. Simply, they just cannot afford it. Then over time, then premiums go up for everybody across the board. So we all want to pay for it. So you are absolutely correct in your analysis in that this becomes a downward spiral for the entire industry. And then every Connecticut resident will be impacted by this.
Great, thank you. I just want to talk through, because I think there's 3 different subpopulations that are all impacted slightly differently on the exchange. I think James did a great job of describing HR1 direct change to those under 100% of FPL, trying to get some basic subsidies. Up to this point, even though they were barred for 5 years from eligibility on Medicaid, we at least provided them some subsidization. We estimate that people in that cohort could be asked to pay 87% or so of their income on premiums. They're losing all subsidies. That's the difference. That group loses everything, no subsidies at all. There's the next tier of individuals is between 100 all the way up to 400 of federal poverty line. That's a group that will largely divert back to the Obamacare, the original ACA subsidy levels. So they're going to lose some subsidization. They're still going to be able to take advantage of some basic Affordable Care Act subsidies. The next cohort is another one that's hit pretty dramatically, and that's over 400% of the federal poverty line. They again will lose all subsidization. So this is, think about hairdressers, small business workers, plumbers, maybe buying on the exchange. To Senator Lesser's point, this is a group that there was a benefits cliff when the original Affordable Care Act was implemented. That cliff was addressed temporarily through the reconciliation package under the Biden era, but has now come back. And so those are going to be 3 particular groups that we're looking at. Within that middle group, this is where I said Covered Connecticut will help be a buffer, because it is true, Connecticut as a state will have to ante up more money. We estimate $30 million over 2 years over this biennium to pay for the cost shift as a result of some of those Inflation Reduction Act subsidies going away for a Covered Connecticut population. But statutorily, that program is created and is set in statute to provide all premium assistance and all copay and out-of-pocket costs. So the shift will be absorbed by the state budget in this biennium. But you're right, Representative Shake, there's other cohorts, and we need to be mindful of price sensitivity. Who is most likely to be protected if we have limited state dollars? Where do we deploy those strategically to keep coverage up? And I think that the other thing that James is doing really well is trying to create the infrastructure for person-to-person counseling, broker academy, so that maybe someone who had purchased up, maybe they were using those enhanced subsidies to buy gold level plans, maybe they're counseled into a silver plan, and that's sort of the happy medium where they can at least maintain coverage. There's also some new flexibilities under HR1. We're still trying to understand where bronze plans are going to be newly eligible for health savings accounts. So there's sort of extra flexibility around bronze plans where you could get some direct primary care and not run afoul of the IRS health savings accounts rules. And so that may be an option. Obviously, all of this is sort of figuring it out. And then the last thing I want to say is Access Health has undertaken a pretty extensive project that's going to launch this year to do these ICRA plans, which is where small employers could sort of unlock subsidies and help people take advantage of the subsidies that exist on the exchange. It may be a more affordable option. And I know James and Access Health have been committed to building out the infrastructure to make it easy for nonprofits and small employers to take advantage of that, offering healthcare through the exchange rather than having their own group plan. So lots more to come. And I think you're pointing on some real granular next steps that we need to be thinking through.
Thank you. Thank you both very much. Same request then. If OPM, if it's this state agency, if you have a flow chart or some type of algorithm in writing that is available for all of my colleagues here, so that those potential impacts of the vulnerable specific populations of what that would mean in terms of number of people and then the cost for that. Thank you both very much.
Thank you, Representative. I just have a comment. I mean, hearing this, so as of January 1, people will experience having 87% of their income have to go to their health care or pay $4,000. I mean, so the family of 5 example, making $140,000, $4,000 a month for healthcare. No one can do that. They're not going to do that. So our session doesn't start until February. So what is the plan? When can we come back together and have a plan in place so that people do not lose their health care come January 1?
It's a good question. I think that's why I pointed out earlier, and I'll let James, if he's still on.
I'm on.
But October 1 is going to be
So-
critical because we've already heard some signaling from the leadership of the Democrats in the Senate and the House that they believe there's a healthcare crisis impending, and they've pointed squarely at these subsidies going away and it not being addressed in HR1 as being a huge cliff that's going to be catastrophic. Thing two that's related to that, states that have not expanded their Medicaid populations, has not done Medicaid expansion, are even more vulnerable. So red states tend to rely much more heavily on the exchange and the subsidies than blue states, actually. So the hope is after we see the resolution of the federal funding fights and whether we get to a budget by October 1 or shortly thereafter, we'll know, has Congress completely abdicated their duty to reinstate these, in which case we need to be thinking strategically as a state of where and how we can plug some of that gap.
Thank you, Representative Gilchrist. Very quickly, we are planning to communicate effectively across the entire state, but we're going to be very targeted communication, especially the family that I use as real example in Fairfield. There may be other options for them on the exchange. Maybe as I think that Claudia indicated, maybe now they have a gold plan. Maybe they could go down to a silver plan or a bronze plan that would fit the minimum needs that the family has, and maybe the 4,000 a month could come down to about $2,000 a month, or whatever it's going to be, depending on what the rates are going to be for 2026. So we will leverage our broker communities to work with folks who are being impacted with the increased premiums to try to ensure we have continuing coverage for everybody on the exchange currently. Again, that's a very optimistic approach, but we believe that it's doable, and we will do everything we can to ensure that those who are losing coverage because of cost, is there something else we can do for them on the exchange by having them purchase a lower cost, although less coverage, but more affordable for them and their families. That's one. We are also working very closely with we have over 2,000 community partners that we are targeting the most vulnerable in the community, especially those who may be losing coverage, who may be losing Medicaid. How do we get them on the exchange to minimize a gap in coverage for them as well? So part of our objective, and then when we were created, is to lower the uninsured in the state of Connecticut. So that's always a driving force behind everything that we do. So again, working closely with DSS and OPM to ensure that Connecticut residents have a viable option to get health coverage, although much more difficult because of what's going on at the federal level. But we will continue to do our part. And as Claudia indicated, there's a lot of conversation going behind the scene between Democrats and Republicans and the Senate in particular to extend the enhanced subsidies beyond 2025. But right now there are conversations. But when we are planning assuming the worst possible outcome and hope that we are surprised, pleasantly surprised. So right now we are planning as if they're going to expire until we know otherwise. But we do know there's a lot of conversation going behind the scene, but we just haven't heard anything concrete yet.
And I think the natural deadline, if we want to sort of operate by a deadline for something like this, would probably be mid-November when open enrollment starts. So people probably are going to shop based on what they can anticipate getting for subsidies. So that's going to be, I think between October and November is going to be a key area, because if people don't know and they're signing up on an open enrollment, they're locked into that plan. They may be disinclined to overextend themselves or get coverage if they don't know they can count on certain subsidies and premium assistance.
Wonderful. Thank you. Do you want to wait? I've got a list. Yeah. Senator Anwar, followed by Representative Dathan, followed by Representative Hughes.
Thank you so much, Madam Chair. Mr. Michel, thank you so much for your work and your entire group that does, and you've been very helpful for so many issues. And every time I reach out to your department and your organization, you do a great job and help us out. I want to talk a little bit about reaction, and I think it's related to a number of things people have spoken about. But it is my understanding that there's an opportunity from a policy perspective to improve the risk pool to reduce the cost. We cannot change the federal laws, but we can do some things at the state level to be able to help out. Um, can you help us? And it's my understanding that some of the states, Minnesota, Massachusetts, New Jersey, they're exploring some options. Have you heard some best practices that can be looked at and then we can learn from and perhaps make our own path or use somebody else's?
Uh, Thank you, Doctor. We are looking at, we have spoken with Minnesota, and again, I'm part of the Nashville organization where all the state exchanges exchange and share ideas. We know the risk pool, the bigger the risk pool, the better it is for everybody.
Yes.
Right. So states are looking at different options. How do they expand the risk pool by offering the plans that are more affordable of other folks, and also how do we make the insurance healthcare overall more affordable? They're looking at different combinations of in health insurance and low cost of healthcare. Right now, they are exploring as we are exploring. Again, as we move forward and have more conversations, if we have any concrete thoughts and ideas, we will certainly share them with our board and also with OPM and bring them forward to the state legislature for consideration.
Sure. And I'll just speak to two ways of approaching things right now. I know there's been a suggestion to have a wait and see approach. I'm not sure I agree with that. I think we'll have to have a plan of action based on the knowledge that we have today. And if things adjust, we adjust. But if we don't have a plan from currently, I would call it a terrible case scenario. And if the scenario becomes a little better, that's good. But let's be prepared for the bad or terrible case scenario that we should all be working towards. And then in order to be better prepared, we need to have a chart to be able to see what's going to happen with Medicaid. What are the gaps that will be created by that? Which gaps can the exchange help us with? And then we find out what would be the opportunities to address some of the areas that and our citizens in our state to make sure that we do the best job. So we would love for you to, and I will encourage everybody who wants to wait and see, not to wait and see. We have to be ready for whatever happens.
Unfortunately, we don't have luxury. We don't have the luxury of waiting and seeing. So when November 1st comes along, we got to be ready to go. And we start sending out notices to our current customers in mid to late October for them to come in so that they know exactly what the impact is going to be to them. So we are assuming that the enhanced subsidies are going to go away until we hear otherwise. So early in mid-October, Connecticut residents who are currently purchasing insurance from the exchange will be getting notices from us projecting what the new premiums will be on January 1, 2026, based on reduced subsidies without any enhanced subsidies. So it's going to be dramatic. They're going to see it. So unfortunately, this will be not just in Connecticut, across the entire country. This will create a lot of concerns across the population in the entire country, because some folks are going to start getting notices telling them exactly next year premiums will be going up by X amount of dollars because enhanced subsidies going to go away. And particularly those who have income above the 400% of FPL, they will lose all subsidized coverage, which means that they will have to pay the entire amount out of their own pocket. That's going to be the biggest dramatic in change. And also those who are most vulnerable, who are here for less than they're earning less than 100% of the federal poverty level, and they don't qualify for Medicaid, and they're barely going to be able to afford to live, much less paying the full value of the health insurance coverage. So again, part of our strategy at Access Health is to communicate, and go into the communities and talk to the people in person. Talk to them in person, and we're going to send letters, we're going to send notices, we're going to call them, but we're going to have events throughout the state, leveraging our own data system, data sources to target exactly those who will be impacted the most. We will go there with our brokers and talk to them and try to help them shop,
Yeah.
pick the for them and their families.
So I look at this as a human caused disaster, and in a disaster, the people in the community come together. So with this, just count at least me, and I know many of my colleagues will join to be able to get the word out, to try and get the enrollment to have the right risk pool. The broader the risk pool, the better, as you're saying. So that would be one of the areas we can help you. The other part, if there was information that you can provide us, there's conversation about special session. And while many of us may not be the ones making the decision on what's going to be on the agenda, it's important to have enough data so we can at least advocate on our side for what should be on that agenda. Perhaps this is a fix that we can start to look at from a policy perspective, but also funding perspective, and if possible. And then from a policy perspective, if you can help us as well, sooner or in February of 2026, that what we need to do. And I know you mentioned that you have all the data with respect to the costs and so on. So getting more insight into that would be helpful, so we are better prepared and look at all possible scenarios. And I wanted to just thank you, and thank you, Madam Chair, for allowing me to ask the questions and make this comment.
Thank you.
Thank you, Senator. Representative Dathan, followed by Representative Hughes.
Thank you so much, Mr. Michelle, for your testimony today. It's very helpful, and it's also a real wake-up call. I know earlier when we talked to DSS, we were strictly talking about Medicaid, but you are highlighting really the issues that we have with the exchange and what sort of unintended, hopefully unintended consequences of this change. I appreciate that you highlight the 5,000 residents affected by it and what that could mean. Are you aware of any other opportunities that the state might have to open up maybe some state plans to help capture these? In a sense, maybe a separate sort of public option for residents who might not be able to qualify for this. And if that is off the actual exchange, how that might affect what you're doing. And then I do have another question for the Undersecretary in regards to some of these expenses that you highlighted.
Representative Dathan, we have looked at the public option, a version of public option. As you know, or as you may know, New York State has a public option available to its citizens, and it's very close to Medicaid type of plan where they leverage the Medicaid network and send and pay. So we have looked at it, but we have not made any progress. Meaning not actually separate as a state. Maybe it's worth another look to see whether or not a public option study. We have looked at it, and we've had some costs, potential costs over the years, well, several years ago. So maybe we'll pull that back up and look at it and work with OPM and get back to you in the committee after
Yeah,
we've
that'd
done
be
the
helpful.
study.
I know we allocated some dollars to it in our last budget. So I do think that there's an opportunity here for us to really understand. I mean, obviously, we don't want to put undue stress on our state plan. But, you know, we do have to consider the cost and the return on this. So thank you very much. I did have a second question for the Undersecretary, if he can prepare himself. Thank you so much for sticking around. Our FAC meeting scheduled for the 4th of September was canceled. And there's been some highlights of expenses here that we will incur. Is OPM considering this adjustment for the FAC, or how are we looking at some of these different dollars and how we will allocate these going forward? Thank you very much.
It's a good question. It's probably one that I need to follow up with. Obviously, I want to talk to the secretary about. I think there's a couple different options. FAC, is limited in that we would have to identify clear lapses within that agency, and DSS is the one that's sort of triple hit here with a lot of different things coming all at once. So that might not be the best way to figure it out. I mean, obviously, we have the possibility of a deficiency bill towards the end of session if need be. The other thing is we're actively looking at whether and how we could get advanced planning documents to get a 90-10 match on some of the systems changes. So OPM is in conversations with DSS to explore that. That would bring down the cost significantly, and we could probably start to get a jump start on that work relatively soon.
Thank you very much. I fully agree, and I'm glad that we're looking at this, and I'm glad we're also talking about it coming outside of FEC, because there will be significant deficiencies. But I do fear that waiting till the end of session is really going to put us on a back foot, and the citizens and residents of our state need to know going into open enrollment that's happening in the next few weeks how we are going to manage that. And I do hope OPM and Access Health will make sure that communication, there is some sort of marketing campaign that we're doing to make citizens aware of what is happening here and how the changes could really affect them and how much they're actually having to pay. Because I fear that many people will decide not to go through that, thus increasing the risk and the loss ratio in the pool. So appreciate that and look forward to hearing back from you as we progress through the next coming months. Thank you, Madam Chair.
Very quickly, Representative Dathan, just so that you know, we do have a robust campaign laid out and identifying. It'll be very targeted. And again, our data tells us who we need to talk with about certain topics. So we'll be doing very targeted outreach, marketing, in-person events for those we know will be impacted because of all the changes that we've just talked about. But we also do have some mass media as well. But most of our resources will be targeted with folks who we know will be impacted.
Thank you.
Thank you, Representative. Representative Hughes, followed by Senator Lesser.
Thank you, Madam Chair, and thank you, Undersecretary, for holding on just one more second. I think it's so ironic that the HR1 may be forcing states like us to open up a public option like immediately. And I'd like to get an analysis through OPM, Access Health, the Comptroller, and Office of Health Strategy, what that would look like for the 3 cohorts that are going to be impacted, for the 3 cohorts in our state, and the costs of opening up either state partnership health plan, state employees health plan, what that would look like to increase our risk pool and keep it together, and whether we could partnership with New York, Massachusetts, Rhode Island, and other states that are looking at the same.
So I think the good point that you're bringing up, and this follows on Representative Dathan's forward thinking, is that there are things that we can do in the short term, and there are things we need to be thinking about in the longer term. So in the short term, unfortunately, our tools are relatively limited. We need to do no harm. We need to stabilize the exchange. We need to keep insurance coverage rates high. But I think you're all pointing to some real active conversations that are probably going to happen in the off session and during our normal policy development and budget development to come back in the midterm with how do we address the underlying root causes of healthcare costs and what can we do better to make sure that we're not only relying on subsidies, and are there more of a layered approach. So I take your challenge, and we'll see you in 27 with a lot of ideas.
Or sooner. Or sooner. Thank you. Thank you, Mr. Secretary.
Great. Thank you. And you good? Yep, Senator Lesser.
Well, a couple of things. Thank you for filling in, Undersecretary. It's good to see you. And I have some questions sort of prompted by Senator Onworth's question, Representative Hughes, Representative Dathan. all of whom made some excellent points and asked some good questions. But um, specifically, you mentioned, Undersecretary, that we have a very narrow window in the month of October where we're going to find out, is Congress going to allow Connecticut residents to see a quadrupling of their insurance premiums that would just devastate middle class families or not? At some point in October, they may let us know, they may not. Congress works on its own schedule and they don't take us into account. So Congress could decide to fix it in October. Maybe they decide to fix it in November or December. But it's not really up to us. Or maybe they decide to do nothing and focus only on the tax cuts for the wealthy and nothing for the middle class. So we don't really know. And then also at the end of October, we have a decision to make because we heard that we have to provide notifications to folks about what the premiums are going to be on January 1st. So October is going to be really critical. You heard earlier that Rhode Island said, look, we have a rainy day fund. This is clearly a rainy day. We don't know what Congress is going to do or not, but we're going to make sure that we're going to provide state-based subsidies to make up the difference. If other states can do that, if our sister states can do that, could Connecticut do that? And if so, is that something that we could do as an insurance policy? And obviously, if that federal money comes, then we don't have to take any money. Hopefully Congress does come to the rescue, and the president doesn't want to be known as the guy who quadrupled Connecticut residents' insurance premiums, and that causes a meeting of the minds. But if, as an insurance policy, can we look at a rainy day fund and look at that as a potential guarantee?
Here again, I'm going to wait till October 1 because I think it's so important. I understand when you say Congress is on its own timeline. The key is if the appropriations package at the federal level are going to happen in a bipartisan fashion, we'll know by October 1 whether there's going to be a bipartisan deal. And I feel pretty confident that if Democrats are in the room in the federal level, there may be a good shot that this will get extended. So we'll know if there's a breakdown in conversations and they go the route of only a partisan CR. That will give us a lot more intel and we can make a credible decision of what to figure out. The only state I'm aware of that's taken proactive action has been Maryland. And they have created the authority for an assessment on providers to backfill part of the subsidies. They recognize they won't be able to do all of it, but they did before they adjourned session have this ultimate backstop with a fail-safe that says that if the feds come through, obviously, you don't move forward. So we will look at, and I suspect, put options before you in the short term, once we know a little bit more after October, for what the state may be able to do and how we can best protect the most vulnerable.
So there's one other question, and Representative Dathan and Representative Hughes, I think, mentioned it sort of obliquely. But, I heard earlier we have a new requirement for Medicaid that we do cost sharing. Now, I think that's a little silly, but there is a sort of a wrinkle, which is if we're looking at a lot of people losing affordable coverage, maybe we could go the other direction and lean in on cost sharing, lean in on assessing premiums, and just simply charge folks who are losing their subsidies on the exchange, who are losing coverage through other options, the cost of care, and allow them to essentially buy in. Is that something that the administration is open to? Is that something that, because we're gonna have a lot of people losing coverage on the exchange if they don't act on October. I wish I had your confidence in Congress, but assuming they do nothing, we're gonna have an awful lot of people lose coverage on October, on January 1st.
Let me restate: it's not a confidence I have in Congress, but a confidence that we'll know a lot more by October. Is all I have confidence in. To your other point, Senator, I think we can certainly, cost share changes don't go into effect until October of 2028. So we have some time before we'd have to impose any cost shares. It also coincides with roughly the time when our covered Connecticut 1115 waiver would have to come up. So it may be an interesting conversation to have of whether we roll that population into covered Connecticut and are then able to can we circumvent the entire cost share subsidy conversation because they would be under a different program. So I think there's a lot of opportunities we have between now and the 2028 to figure out what makes the most sense. And, that's what we'll come back with in the midterm.
I'm asking slightly different question. I'm saying instead of, we don't have to do it until 2028. I'm saying maybe we want to do it now. So we want to do cost sharing immediately as a way of trying to figure out some place for folks who are losing coverage to go. But, and no, understanding that the state doesn't have the resources to provide free healthcare for our residents. I wish we had that resources. We don't. So given that we don't, I'm just trying to think if that's a way, if that's something we might want to look at more quickly.
Look, I think any good ideas are on the table, and we ought to be thinking about every good idea and how it works. And to the point that Representative Sheikh said earlier about, I think we need the data, we need to evaluate the feasibility, the operational implications, and really look at the flow chart. I think that's good evidence that we'll have to take back and pressure test all these ideas to see what works and what makes sense for Connecticut. I know the governor is very keen on making sure within a sustainable fashion we protect the most vulnerable and try to figure out how Connecticut can lead. So we've been tasked with coming up with a lot of different creative options to do that.
So I obviously what happens or what doesn't happen in a special session is above my pay grade, above all the folks here's pay grade. But if we're talking about making some very big decisions in the month of October, and we will have that information by October, I just think one of the things that absolutely needs to be on the table is looking at the potential of expiring federal tax credits and see if there's any way for the state to provide a backstop. Otherwise, if that's not on the table, people are just going to be shocked on January 1st when they lose insurance coverage, because the numbers of people affected are going to be staggering.
Thank you, Senator. Thank you. Again, I want to thanks folks for their patience. We are over time, but we're going to keep on going. So if you do have a hard deadline and you are scheduled to speak, if you could let our clerk know, Brianne, that would be helpful for us. Now we'll move on to Mairead Painter, the State Long-Term Care Ombudsman, who will talk to us about the impact on HR1 on aging and disability services. Good afternoon. Thank you for being here.
Good afternoon, and thank you for covering this topic today and looking for information regarding HR1 and how it's going to impact individuals related to long-term care. Pausing the enforcement of the federal minimum staffing rule in nursing homes delays critical regulations that ensure that residents receive necessary and adequate care. And I didn't say quality care, I said adequate care because it's a minimum staffing level. This was originally passed after years of advocacy to address the chronic understaffing in skilled nursing facilities. As this has been a systemic issue that has resulted in poor care, increased hospitalizations, and diminished quality of life for individuals living in low-staffed facilities. This pause, coupled with the proposed Medicaid funding cuts and added layers to the enrollment process, creates a serious threat to the well-being of residents and staff. For years, skilled nursing facilities across the country have had inadequate staffing levels. This has led to delayed or denied basic needs such as help getting to the bathroom, accessing fluids, participating in activities, getting repositioned, or then receiving wounds. Higher rates of hospitalizations and injuries due to insufficient supervision and care, as well as staff burnout and turnover, which we can't afford to have. And this is as a result of the emotional strain and physical exhaustion. Staff often report to my team and I that they're really upset about not being able to provide high quality care to the individuals they're serving because they want to be able to do that, but they feel really stuck. And this all comes at a time when more individuals are receiving their long-term services and supports in the greater community and choosing to go into long-term care facilities when their needs are greater, right? They have a higher level of care. This means that staff in the nursing home need to have more time to spend with each resident. Without appropriate staffing levels, residents face increased risk of falls, particularly in the bathrooms, missed meals or lack of assistance with feeding and nutritional support, bed sores or wounds due to not being able to be repositioned or repositioning themselves, and medication errors as nurses are really stretched very thin. And the neglect of individuals with cognitive disorders resulting in unnecessary isolation in locked units and without proper supervision. I'll add that overburdened staff are often more likely to experience burnout, which correlates with a higher risk of abuse and neglect. This is something that unfortunately we have seen, as now there's videos in residents' rooms, and we are seeing some of that taking place. Then there's also the issue of chemical restraints to manage residents physical expression of their needs, or what we call behaviors in some cases, especially those with dementia or other cognitive impairments when living in a facility with low staffing levels. The use of chemical restraints severely diminishes the residents' autonomy and quality of life. It increases their risk of falls and injuries, and it fails to look at the root cause of the issue and often results in this harmful cycle just reoccurring. HR1 also includes significant Medicaid funding changes that further impact access to care, like the retroactive coverage reduction from 90 days to potentially either 60 or 30. That is going to have a significant impact to the individuals we serve. Depending on that person, the risk to access to qualify for facilities could make facilities less likely to accept people who are pending Medicaid. This may back up the hospitals and prolong the time a person will have to wait to receive the level of care that they need. This could also cause people to return home to the community without the access to the care that they need, putting them at risk for higher impact to their health. Stricter eligibility rules and complexity may delay access to care. This is particularly harmful for individuals in need of urgent long-term care. Broader cuts to programs like SNAP and other mental health services for people with disabilities and older adults will impact their ability to maintain their health and potentially lead to the need for admission to a skilled nursing facility and care sooner, creating a higher demand on the long-term care system. These changes place a greater burden on residents who receive Medicaid, both financially, the barriers, and administrative obstacles that will delay care and increase risk of adverse outcomes. The combined effects of HR1 Medicaid changes and the pause in mandates represents a threat to the quality and accessibility of long-term care. Without adequate staff and sufficient funding, both residents and staff are at risk of and will lead to poor outcomes, higher mortality rates, and further stress the long-term care system. Again, with the impact to decreased insurance and people not accessing care when they should be, we're going to see people getting sicker faster, needing more care, and a bigger impact to our system financially.
Thank you very much. More intense news. Thank you. Representative Hughes, followed by Representative Shake.
Thank you, Madam Chair, and thank you, Mairead, for the real impact of what I call deliberate medical neglect of HR1 on our people, leading to preventable deaths, preventable injuries, harm, and death. But I really want to dig in a little bit to what you said about the stretched thin care workforce and going upstream on how this is going to impact their reimbursement rates, the staffing cost rates, those kinds of things, how this will really impact an already stretched thin workforce. We in the Aging Committee, as you know, have tried to increase direct care times. We've tried to increase coming out of the pandemic. We tried to address some of those staffing ratios, some of those pay ratios, make sure that Medicaid rates were going to pay the care staff, not just, administrative costs and that kinds of things. We tried to put some protections around there, tried to look at private equity, all those kinds of things. None of that matters if, if the reimbursement Medicaid rates are slashed and they're not getting the care, because that's basically imposing medical neglect because the staff can't meet those minimum staffing requirements, ratios, direct care ratios. And when long-term care folks don't get fed, when they don't get turned, when they don't get medication on time, it is catastrophic for already fragile folks. So I just wanted to dig in a little bit about that staffing piece that you mentioned. Thanks.
Sure. So staff go into this role because they care, right? And they want to do a good job, but it really is burdensome to them. And that's why we see some of them leaving the workforce as we're trying to build the workforce. So that makes it really difficult. And people should be able to feel proud about the work that they do, where they work, or where they live. And we don't find that across the board, especially when someone is working and experiencing tight staffing. I'm not talking about a few call outs because of a bug going around or something that might impact a nursing home from time to time, but we have nursing homes that are chronic understaffers. And I think this not only at a federal level is undermining those staffing requirements, but it says it at a state level, like, do we really need to do this? And we see the impact to the individuals living in those homes and the staff. They get discouraged, or they go to a building where they're going to be able to staff well and feel good about the work they're doing.
So you really, thank you, Madam Chair. You're really describing a cycle where this further diminishes the care in those understaffed homes that we're unable to address because we can't pay them enough, because we can't create a safe staffing ratio, and those care recipients are the ones harmed.
Correct.
Thank you, Madam Chair.
Thank you, Representative. Representative Shake, followed by Representative Dathan, followed by Representative Johnson.
Thank you, Madam Chair. Good morning still, right? Oh,
Afternoon.
no, good
It's
afternoon.
now.
It's 12:30. If you could reiterate part of what your comments were in regards to the staffing ratio, if I missed it, in a, depending on the population or patient population, what is the staffing ratio? Do you have an answer for that?
I do have an answer for you.
I'd
So
love to hear it.
here in Connecticut, we were supposed to be staffing to, here in Connecticut, we should be staffing to 3.0, 3 hours a day of hands-on care per resident. We have some nursing homes that follow that. My team tracks that in the nursing homes. It's supposed to be posted by shift and updated by shift in every nursing home. We do not find that consistently. And we have some organizations here, some companies in Connecticut that don't believe it's fully in effect yet and are not staffing to it. And so we have nursing homes that are under the 3.0. And I think when we see this undermining at a federal level, it makes it difficult to enforce that here at a state level. We do see DPH going out and working to enforce that, but it's a constant chasing down and very difficult to do. And no one can receive quality care when the totality of your care in a day is 3 hours. We often hear that they have to be in a nursing home because they need 24-hour care. And I argue that it's not 24-hour care, it's 24-hour emergency response capability, because there's no opportunity for the caregivers in those homes to give the level of care they should be and want to be giving.
So the 3 hours that you just referred to, what personnel is expected to be interacting with that patient or
Sure.
person?
So that's direct care staff. That would be the nurse on the unit. That would be the CNAs. It doesn't count social work or therapies or things like that, because not everyone receives therapy. But the people who are interacting with that person and helping them with their activities of daily living, their medication, helping to support them nutritionally by either feeding them or giving them drinks, that's all counted into those hours.
Okay, so the 3 hours, is there a differential between a day shift, 7A to 7P versus 7P to 7A?
There was discussion of that in the recent regs that were proposed that did not move forward. We are currently using the old system of how the hours are just sort of lumped together, and the nursing home puts the hours where they feel they need the hours.
Thank you for clarifying that. So that being said, I have a lot of questions. I'm not going to ask all of them. But my main concern is regarding our long-term care facilities and quality of care. As someone who works in healthcare as a nurse, it's strenuous whether you're in a hospital, but especially our long-term care facilities and outpatient rehab facilities. And those workers work very, very, very hard. The impact of HR1 before it is now applied here in Connecticut, what would that look like? Like what, if you feel comfortable being able to answer that, how much, is there like 20% less staff, 30% less staff? How does that impact? Because what I'm hearing is, which we know, not having enough staff to properly care for people leads to negative outcomes, fatal outcomes, near misses, you name it. And DPH can only do so much in this capacity right now, whether it's DPH or DSS, That's again, these two big agencies that are going to have to figure out how this is going to be impacting residents here across Connecticut. But with the staffing that you're raising your concerns about of not, we already don't have enough people working in those said facilities. How much of a reduction, did you say it already in your comments? Further reduction, I guess, would we be seeing here in Connecticut?
Because we have a state rule for 3.0, we shouldn't see that much of an impact related to the daily hours. We're also a state that already requires a nurse 24/7 in a nursing home. So I will thank you all for that and hope we never see that change, because there are states where a nurse is, RN is not required to be in the building at all times. And I think that has a huge impact to quality of care for individuals living there. But because we have those things in place, I don't think we'll see a huge impact on the 3.0. We need to see the 3 hours a day of care upheld here in Connecticut, enforced, and make sure that people know that it is in place as a minimum, that these are minimum staffing levels. These are not high-end staffing levels, and this is to get basic, adequate care, not for people to have the high-quality care that I think we all would like to see.
So are you coming to us today asking us to make sure that we're conscientious that that 3 hour, I don't know, 3 hour window minimum, thank you. The 3 hour minimum is what stays in place as we move through how HR1 is going to be impacting Connecticut long-term care facilities? Just want to make sure I'm hearing you right.
I'd like to see the 3.0 stay in place, as well as, to your point, the defined hours as to who needs to be in the building at what times in order to support quality of life around mealtime, around times when people want to get up and get dressed or attend activities, requirements around that, and stick to who can provide that care.
Like a PCA versus CNA versus, what does that
A
mean?
CNA versus a nurse that may be in an office working doesn't count to the floor. It doesn't count as a hands-on care provider, would be one thing. And then just being able to access the nursing home, the change in the presumptive eligibility is going to be huge, and how nursing homes decide who they will accept. A lot of our individuals who go to nursing homes need that 90 days. It takes them that long. You're in the nursing home. How are you getting your bank records? How are you getting all of the paperwork that you need to get in order to qualify? That can be really difficult if you don't have a direct family member or supportive friends that already have access to those things. You might have to go through probate court. So all of these things lengthen that period of time for someone to become eligible. And if the nursing home has accepted them, they deserve to be paid. And to make sure that if they're only doing that window of look back, we don't want them to go without the dollars they need in order to appropriately fund the nursing home.
Thank you.
Thank you, Representative Dathan, followed by Representative Johnson.
Thank you so much. It's so nice to see you in person. I wish it was to discuss different things, but appreciate it nonetheless and all the work you do. One of the concerns we kind of touched upon today was really the workforce. And I'd love to, bearing in mind the report that we got at the end of December on the long-term care, and the projections on how the numbers are shifting and how they're growing over time. I know one of the things that came out of HR1 was reimbursement for educational federal loans and the ability to get federal loans. And if you are not making a certain threshold of income, then you wouldn't qualify. And I know with many of the people that are working in these long-term care settings, as you said, it's a calling, but they do require education, they do require training, and they do require a lot of things. Has your agency or anyone else within the administration here had a look at how this could affect the workforce for people in the long-term care settings? And also, if you've heard from any of our long-term care providers, any sort of decrease in staffing as a result?
So as far as the greater administration, I'm autonomous, so we don't I don't have that level of knowledge about what they're thinking about this. I do talk to my peers at a national level, and we are very concerned about that because it's already very challenging for individuals in long-term care to access a specialist, to access care even outside of the skilled nursing home. And they work to try to get those connections for people, but it's hard. Dental service, podiatry, those are areas where we already see a shortage of individuals willing to serve individuals on Medicaid because of the rates. And if we deplete that pool of people further, I think that's going to become harder and harder, and we're going to have more of an impact to the individuals we're all working to serve, and a higher demand on the hospitals. But the hospitals are going to get clogged up because they're not going to be able to appropriately discharge people or connect them to services, which they also want to do. We hear from them that they would love to be able to do that, but they can't do that because they don't have places to refer people on the other end. And I think the mental health piece and people seeking mental wellness is going to be a huge challenge moving forward because of the gaps we're seeing in the greater community is going to cause people to need support at higher levels of care. And then again, that's just going to further impact the greater system.
I fully agree. I know in my community, Waveney Cares does a wonderful job at training and helping individuals who do want to go into this so that they don't have to pay for the training themselves, but they get trained, hands-on training, and then they're also getting a paycheck while they do that. I'm hoping we can encourage other providers in our state to offer similar sort of services so that folks will be able to get the training they need, satisfy the sort of staffing requirement ratios that we need to have to keep our residents safe. And we haven't even talked, I mean, you know, you work a lot with the long-term care kind of less in-house and more, you know, sort of not institutions, but providers that have in bed facilities. So we're also going to see the knockdown effect on those. And it'll be great for us to continue this dialogue. And with your knowledge of what other states are doing, I know from the long-term care report, we rank 22nd in the country for how much we spend on it compared to other states. So we're pretty much in the middle. But I'm curious how this is going to, the staffing will affect that and what's going to happen to our neediest residents. So again, thank you so much, and great to see you here today.
Thank you.
Madam Chair.
Thank you. Representative Johnson, followed by Senator Lesser.
Thank you so much, Madam Chair, and thank you so much for your testimony and your work today. I just wanted to follow up on the idea that the change in the amount of time that we'll be able to look back for people who will be applying for Medicaid will have an adverse effect on how. And I know you had mentioned that, and I'd like to have a little bit more from you on those systems. We're already, as you know, and you stated, having a problem with people who have behavioral health difficulties and having the nursing facilities not really want to have them admitted into those places because of the federal requirements in terms of how many people with behavioral health problems can be in a particular skilled nursing facility. And I just am very, very concerned about the backup in the hospitals and how that will impact them and what will happen to people once they're perhaps moved out of the hospital. I have numerous people in my district who have been in a hospital and then moved to a homeless shelter. And these kinds of things are really dysfunctional as far as I can tell. I'm not sure that's been the case in a lot of other places, but I just wondered if you had additional analysis on where we should go, our policy on this issue.
Thank you. So I think I'm going to try to hit on some of the points that you brought up. One being that, yes, the time for a look back and the time it takes is difficult and depends on what someone has in place and how they have their documents. And that can change, especially for someone who maybe their housing security isn't as good as my housing security. And I have all my documents in one place, and people can lose those documents. So that increases the time. As far as discharges to shelters, we have seen a little bit of an uptick. I don't have, as far as the nursing homes, we can see and track that, and the residential care homes. I don't know as far as the hospitals, but we have heard of some. But I think it is getting more challenging for them to find places for people to go. We've heard of people being in the hospitals for very long periods of time, months and months, because either mental health or it's related to their funding. There's lots of different reasons why they may not be accepted to a skilled nursing facility. We will probably see that grow. I would anticipate that we'll see that grow. Also, individuals who are new to this country or are here and then have a health crisis, I think we're going to have an impact on where they're able to get care and their access to nursing homes, and if they're going to be able to be cared for in a nursing home, or if they're going to be stuck at the hospital level, and what the hospital is going to be able to do to support them.
I would love to be able to create additional policies that would create a possibility of either creating a facility that isn't a skilled nursing facility certification, maybe one that's a rest home certification, or one that doesn't require all the requirements. Say that you would go to a non-skilled nursing facility that we used to have back in the day. I think we still have some of those, but it would be good. I just don't know if we've looked into that, where we could go, because I know my homeless shelter people have a real hard time dealing with people with behavioral health problems, and they aren't really set up to be able to address those needs either. And people just end up out in the street. So it's a very difficult situation to figure out how to transfer people into a safe place, like is required by the federal law or the Medicare and Medicaid certification for the hospitals, so that they will get that they're supposed to get under those programs.
Yes, so we do have residential care homes in Connecticut. Unfortunately, we've seen several residential care homes close when it's an area where I think we need to see grow. There are some pockets of the state, including Eastern Connecticut, where it's very difficult to try to find a residential care home bed. But it does provide for individuals who are not at nursing home level of care, or if they are at nursing home level of care, then they can receive home and community-based services, which has been incredibly helpful. We've been working with the residential care homes to make sure that they meet those standards. We've been doing interagency education with DSS, DPH, DEMIS, and my office to try to support the residential care homes. And we're hoping that we see other ones open. We've seen a few open over the past year, and I'm hoping that that continues, because I think it's going to be necessary in order to support these individuals who are kind of caught in the middle between the nursing home, and the RCHs are state funded. Many of the individuals there receive state funding to help support them.
Great. Thank you so much. Thank you, Madam Chair.
Thank you, Representative. Senator Lesser.
Building off of Representative Johnson's question, it's clear that we need to sort of rethink in the wake of the Republican budget bill, the future of long-term care. The idea that we could rely on Medicaid funding as a sustainable source for, this vital population is just increasingly untenable at a time when the federal government is just walking back from its commitment to our seniors and to people with disabilities. I don't think we're going to be ready to reinvent long-term care in a special session coming up in a month, but we should probably start that conversation sooner rather than later. I know that in Washington State, the state has created its own, I guess it's a statewide funding mechanism for long-term care. And I'm not suggesting that Washington has figured out the answer either, but they're at least further down the conversation pathway than we are. And so I'm just curious if you had a sense of, I'm not asking where we should wind up or how we get there, but, or maybe what sort of initial process would you identify as a way of us sort of thinking about where we're going to make sure that at a time when we're going to lose states on the whole are losing over $1 trillion for the Medicaid program. The funding goes to nursing homes, right? That's where the money goes. So how are we going to make sure that the residents in this state aren't affected? And then I have just a very sort of, so I'd like you to sort of just comment on what process you might be able to anticipate about how we could plan or have that conversation about the future. And then I have a very technical question, which is we heard from the folks at DSS about folks who could lose coverage. I mean, I'm thinking of lawfully present immigrants, et cetera, who are losing coverage. Are people going to have to leave nursing homes who are currently there? Is that something that we're looking at? And how many people are we talking about, and where would they go?
All right, I'll start with the first question. If I had the opportunity to envision what it would look like, and so Patricia, who's the state ombudsman in Oregon and, in Washington, we've talked about this, and their setup is very different. They have moved more to the small home model. So they have very few, for a large state, they have, I think, under 30 nursing homes. They have very few traditional nursing homes the way we would see them. And they are for people who are extremely frail and individuals receiving rehab services, intensive rehab services. Other than that, they have a small home model where individuals live in their greater community in small homes that are run like the nursing home. They receive all their skilled care in those communities. And I think this session we started last session we started talking about that in opening the bed moratorium and really encouraging nursing home owners to build smaller communities. I would love for nursing home owners to build a system where they're a hub of care, which we've seen with some of the CCRCs, where an individual can go and live there and they're in their greater community. Maybe they own some residential care homes. Maybe there is the traditional assisted living where they're getting that additional income, but that someone can stay in their community of origin and receive the care they need at any level they need. And that way the owners as well still aren't losing where they see they're losing that admission, they're losing that person. When I worked in long-term care, that was always, you wanted to make sure that you had the beds full. If you create beds in different levels, then the beds will be full. People won't be leaving to go out of your system if you provide a good system of care. So I think we need to focus on that, what that could look like, how we can use some of the current housing or opportunities in our greater community to repurpose it. We have some closed nursing homes I would love to see repurposed into housing that are already accessible, and integrated use housing. So you have people, maybe staff living in the housing with their families and really making it a community versus that's where those people live and this is where we live. And for your second question, yes, I think at some point we've started to have some of those questions. What do you do for individuals who maybe can't prove, right? So now there's going to be there's new layers, like we said, to proving your status. How do people get that information if they've lost it? Can they get it from, we've had some questions about getting records in Puerto Rico. Can be very challenging, where those individuals would otherwise be here, be entitled to care, but getting that information in time for them to be able to be in the long-term care communities can be quite challenging. And so I think we will start to see more of an impact to individuals as we move forward, and as they're trying to get into a nursing home bed from a hospital.
Great. Thank you very much.
Thank you, Senator. And thank you again for being here and for sharing this information. Look forward to working with you as we come up with solutions.
Thank you very much.
I guess I should have checked. Are the two public speakers on the Zoom? Jessica, and if not, I had told them 1 o'clock, but, oh, okay. So again, my apologies since we're going over. Gonna go to Jessica Patronella, who is with the Potential Public Impact. Jessica, go right ahead.
Good afternoon. Thank you for the opportunity to speak today. My name is Jessica Petronella, and I work for United Food and Commercial Workers Local 371 out of Westport, Connecticut. Today, I'm speaking on the federal cuts we're facing to the SNAP program and the impact it will have on our members in our union. The bulk of our membership is part-time grocery store workers who are also low-wage workers and benefit from the SNAP program. UFCW is very concerned about the federal cuts to the SNAP program, which many of our part-time members receive. Not only will people have trouble feeding their families, but these cuts will directly impact union and non-union retail food workers and other low-wage workers in Connecticut. The amount of hours a part-time grocery store worker is scheduled per week is based off store sales. Cuts to SNAP will mean less people buying food and less hours for our members. Not only will our members lose hours, but they could lose their major medical. Our members in retail food who work 30 or more hours a year can qualify for the union medical like a full-timer. This is on a yearly basis, and the part-timer must maintain an average of 30 hours or they'll lose their insurance. Cuts to SNAP will mean there are not enough hours for our members because less people are buying food and sales will go down. Our members won't be able to work enough hours to maintain their medical or pay their bills. These cuts will affect every person working in retail food and every low-wage worker that receives SNAP benefits. We need to keep grocery store workers essential like they were during COVID and come up with a solution to soften the burden of the federal cuts. Thank you for your time today.
Thank you, Jessica, and thank you for giving a variety of perspectives on how SNAP cuts are going to impact folks. Thank you.
Thank you.
Is Maya here in the room or yay, come on up. Yeah, you just have to push the button. Yep, there you go.
Button. Okay, great. Thank you for being here today, supporters and champions. This is a message for you, but also to pass on to your coworkers who may or may not be here today. My voice and my story to pass on. My name is Maya Guyton. I'm a student, I'm a sister, I'm a caregiver. I also have a chronic illness, meaning I will need to take medicine for the rest of my life. I know what it means to fight for family, for dignity, and a future that doesn't abandon the vulnerable. My older brother, Kenny, has autism, and my late brother, Alex, who cared for him, had Vater syndrome and leukemia. Doctor said Alex wouldn't survive, but because of Medicaid and other critical supports, he lived 20 years past than he was expected to. Medicaid didn't just save my brother's life, it gave him a life worth living. The system still failed my brother because when he was in pain and could not work, he did not get the disability he needed. He struggled to live and he struggled to afford to live. Unfortunately, he turned to drugs for pain relief and probably to escape the reality of being failed by a system that took care of him as a child. My mom appealed his case and she won, but however, he ended up passing in 2020. Afterwards, my mother struggled to find care for Kenny, so I became his primary caregiver. At this point, I've seen how fragile the system is. Kenny is always going to need this care, but I cannot do it for long. I'm a full-time student. I'm working multiple jobs, and I do not think this is sustainable. Not for me, not for someone with kids, not for anyone. And this is happening while people my age are choosing not to have kids and moving out of Connecticut. The registry for caregivers is broken. The PTO doesn't make sense. And for 3 years, I've juggled school, work, and guilt. Guilt that my younger brother had to step in and my mom has to leave her job to help. Why are we not checking into a program that you all put in place and defend is fine? Did you know that if I needed time off or just wanted to take a vacation, I have to choose between whether my brother gets care or if I get paid? Kenny is no longer on Medicaid, not because he was able to flourish, but because my mom hustled. He still needs home care and he still needs DDS funding. Without it, he goes from working, he has 2 jobs, thriving in the Special Olympics and learning social skills to being isolated, possibly digressing in his functions because he loses the interactions that he has on a daily basis. This isn't about my family. This isn't just about my family. It's about hundreds of families in Connecticut who will be affected by these cuts. Over 156,000 people in Connecticut could lose Medicaid because of this big ugly bill that passed this summer. Also, as a mentor in school, in college, I met students who rely on SNAP and food pantries just to focus in class. Those programs let them dream and succeed. not just work 80 hours to survive. And trust me, 80 is not a ridiculous number between school, homework, caring for their siblings, their parents, or their grandparents, and having an actual job. These numbers are real. Our investment should be in taking these obligations off children's back, care for our grandparents, put money into schools to offer kids jobs and opportunities. You can't study when you're starving, and the choice shouldn't be perform or go hungry. And nearly 95,000 may lose SNAP benefits, and that's one in every 40 people in our state, and I bet you know one of them. I sure do. Why am I being punished for being poor, for being sick, and for daring to dream? My grandfather was a sharecropper. My grandfather, he was a sharecropper. He moved up north for opportunity, and now his grandkids are struggling to continue his legacy because it's just too expensive. My rent is exactly half of my income. My high school mascot was a pelican. It's Nekede Melis. That was our motto. It means do not yield to evil. The pelican will pierce its own breath to feed its young. And I think that's awesome. I think that's the kind of sacrifice our state needs to make. We cannot yield to cuts. We cannot yield to the cuts that starve people's future. People are hungry, not only hungry, but starving. People are tired, not tired, but frustrated. I'm frustrated. I do not see a future I can live in if we do not prepare correctly for these federal cuts. We're not looking at great programs that function well. We're looking at that are going to have to make it work with less. We're looking at underfunded programs that will shut down and people will have to go without. These are programs that help folks pay for medicine, help me pay for my medicine. I imagine living my life without affording it and without affording medicine that I will need to take till I die. If I can't afford it, I look to a similar course that my brother had. Please tax rich Americans, do what makes sense, build up working families, because the world will not move on without working people like us. Stand with us, stand with me. Thank you.
Thank you so much, Maya. Thank you for being here and sharing your experience, but also for highlighting the fact that the system we have here in Connecticut isn't working the way it should be, that we have underfunded Medicaid and SNAP. And so what we're about to face is going to make things worse. And we could actually take action tomorrow to improve our programs right here. So thank you for highlighting that. Representative Jake, followed by Representative Hughes, followed by Senator Lesser.
Thank you, Madam Chair. Maya, thank you for being here and for sharing everything that you and your family unfortunately have endured, survived. The more people and groups, agencies, PCAs, right, being able to take time to share with us what is currently happening, how the system hasn't been working, right? I think you said it perfectly, where HR1 is an attack on working class people. It's an attack on the poor and all vulnerable populations. So how do we collectively use our power, our authority, right, to then work with all of our residents here who have been crying out for help for a long time. And while the state of Connecticut has made significant improvements, we haven't gotten to that place yet where we're able to capture and then fully give the support that's needed to so many of our residents and families. But what I want to say to you is your reference of why do you have to choose between working and then taking care of your family or even yourself, and to have to go through all your PTO. Where you work, do you have the option of utilizing or accessing our Connecticut Paid Family Medical Leave program? And do your other coworkers? I just want to make sure I'm understanding.
Yeah, we are able to access FMLA and Connecticut paid medical leave. The PTO, which I was referring to, is like any paid vacation time, or if any referring to any time taken off that's not to take care of a family member or because we're sick or anything. This is if I have someone come in to take care of my brother, which he'll need someone if I'm not there. If they're clocked in, I can't be clocked in with my PTO. It just doesn't work.
Thank you for clarifying that. I hope that in whatever capacity you're working right now, that you consider to come up here more and working within communities across Connecticut to share your story. And I know that SEIU 99 is doing that right now with Connecticut for All. But you have a very strong voice and a very significant presence, and I really appreciate you sharing that with us. I think you gave us a lot of things to think about, and how we approach advocating, whether it's special session or the regular session that happens next in February. So reach out to us if you need anything else.
Thank you.
Welcome.
Thank you, Representative Shake. Representative Hughes.
Thank you. Thank you for your story. I just wanted to honor your brother who passed away.
Thank you.
How old was he when he passed?
26.
Mhm. And that was during the pandemic.
Yeah.
Yeah.
Yeah. September.
So he was lacking care at that time.
My brother that passed away, he was when he was struggling to find work, he was able to work with my brother. That was really awesome because it was a lot less of a toll on his body. So yes, sorry, what was your question again?
I'm asking about your brother who died.
Oh, yes, yes. So he did not need care as like for like PCAs, but he actually provided the care.
Okay. So he's working as a PCA.
Yeah, he did. He worked as my brother's PCA until I took over afterwards. But yeah, he didn't necessarily need the care. He was actually trying to get the funding so that he wouldn't have to work. And that's where it was the struggle.
So, but he was hoping to get support and resources like SNAP benefits, like education, subsidies or those kinds of things, right?
Yeah, he was looking for easier ways so he wouldn't have to do a 40-hour work week because his body just couldn't handle it.
Got it.
Yeah.
And those are exactly the kind of people that we are very concerned about with those work requirements and eligibility and administrative costs, qualifying for badly needed health care. That could end up in the same sort of situation and literally young people passing away from preventable deaths. I'm so sorry for your loss. Thank you, Mr. Chair.
Thank you, Representative Hughes. And I also just want to thank you for being here. It's clear to me that this legislation is bad on a lot of fronts, but one of the things it does is it devalues caregiving, and it is, just hard to understand. We need more caregiving, not less, in this country, and it's just shameful. So I appreciate we've had a lot of questions and want to get through everyone, but I just want to thank you for your strength in telling your story. All right. Next up, we have the community health centers who've been very patient here today. So we've got Sabrina Trocchi from President and CEO of Wheeler Health, and we have Karen Daly of CEO of Optimus Healthcare. And could you just come up to yeah, great, thank you, and just introduce yourselves briefly. I'm sorry, you have to press the button in front.
I already failed. Good afternoon. Sabrina Trocchi, President CEO of Wheeler Health. We are a federally qualified health center with locations in Hartford, New Britain, Bristol, Plainville, Waterbury. We have 2 mobile health vans and 17 school-based health centers in New Britain and Bristol. We serve over 22,000 individuals each year. Over 70% of our patient population are Medicaid enrollees. I also serve as the Vice President of the Community Health Center Association of Connecticut's Board of Directors. The Community Health Center Association, across all of the health centers in Connecticut, we collectively serve over 460,000 Connecticut residents, and more than half of the total individuals served are Medicaid enrollees. HR1 and some of the other recently passed federal orders bring significant challenges to the work that we do, to our mission, and most importantly, to the individuals and families who rely on us every day for primary care, behavioral health, and dental services. When we look at the Medicaid eligibility recertification and the work requirement changes that are going into effect, um, I can't understate how a real threat this poses to coverage continuity for all of our patients, for many of our for all of our Medicaid patients. We look at the effective date of January 2027, and many state, well, that's down the line. But what we're beginning to see in our patients is happening right now. And if there was one word that comes to mind, it's fear. Our patients are coming in very fearful that they will lose the connections they have for behavioral health services, primary care services, fearful that they will not be able to continue, and recognizing that if they don't continue to get their care from us, where will they go? When I look at some of the pieces, while Medicaid, of course, is significantly concerning to us, our patients access other services too. So when we look at SNAP, the concern with how that will impact our patients, and we've already spoken about how can you go to school and be educated hungry. How do you engage in your overall health, in your behavioral health, if you don't have the basic needs addressed? And food insecurity is one of those pieces. Wheeler partners with a Connecticut Food Share, and every other week they come on site. Last week they came on site in our New Britain site. In less than 40 minutes, over 200 individuals were served. And that is today when we still have not felt the impact of some of the SNAP and other federal changes. I can't imagine what that line is going to look like when we start talking about potential cuts and reductions. When I look at and so the only other piece I would add related to the January 2027 is we can't wait. We can't wait. We need to start to address the issues today. The Community Health Center and Association and the individual community health centers, we work with some of the most vulnerable populations and residents and communities. We are ready and well poised based on our relationships within our communities to really serve a critical role in working with the state, in educating and supporting our Medicaid residents in meeting the recertifications and the work requirements. But we need to start to define that process today. We need to begin doing that work today. The only other piece I wanted to also touch on, while the Medicaid and the SNAP changes are so concerning, there's other things happening that are also very concerning. So the rescission of the Personal Responsibility and Work Opportunity Act of 1996, which now prohibits non-qualified aliens from receiving federal benefits. Community health centers were one of those identified as no longer being able to serve non-qualified aliens. We are currently waiting for information to be released September 10th. The legal injunctions go away, and we understand what that means. But as federally qualified health centers, it is part of our philosophy. We serve all individuals, all residents, anyone who comes in for care, and to be told that now we need to begin to ask about who is qualified and who is not qualified, and begin to think about denying care is just something that is absolutely overwhelming and not something we want to be positioned in any which way to do. The executive orders related to gender affirming care, diversity, equity, and inclusion. Once again, here we're being put in a position where we need to start to consider denying care, and it's fundamental to the work that we do. When you look at our workforce, it's a workforce that specifically chose to work in federally qualified health centers because of the work that we do and how we will continue to address community needs. And so I will stop there and turn it over to my colleague, Karen, but thank you.
Good afternoon. My name is Karen Daly, and I'm the Chief Executive Officer of Optimus Healthcare. We're one of the largest federally qualified health centers in the state. Optimus serves more than 42,000 patients annually, most of whom are living at or below 200% of the federal poverty level and who have nowhere else to turn to for care. The recent changes to Medicaid, along with executive orders, particularly those tied to the Personal Responsibility and Work Opportunity Reconciliation Act of 1996, which I'll just call the Executive Order for ease, and proposed changes to the 340B program strike at the very foundation of our mission. These changes impact Optimus in 4 key areas: patient access, reduction in revenue, workforce, and administrative burden. Patient access, revenue, and workforce are tightly linked because when patients lose access, revenue declines. And when revenue declines, we lose staff, close sites and programs. And when we lose staff, close sites and programs, patient access diminishes further, and the vicious cycle continues with devastating consequences for families and communities. The changes in Medicaid and the executive order will affect patients' access to services at Optimus because patients will either not meet eligibility requirements or Optimus will be prohibited from providing the services to them. Optimus anticipates approximately 6,500 of its patients will lose their benefits through changes in Medicaid and the executive order. We are already seeing the number of Medicaid patients we serve decrease and the number of patients who wish to complete a Medicaid application or an application for our sliding fee program decrease. While we do not know the immigration status of our patients because we do not ask, we assume that the current political climate is driving some of these decreases. The implications of not accessing timely, quality primary health care have far-reaching effects. It significantly raises the possibility of spreading preventable diseases that can be eradicated or the severity reduced when testing, vaccinations, and follow-up care is provided. Also, when patients with chronic conditions like diabetes or hypertension do not seek the necessary follow-up care to keep their chronic condition controlled and ration medications or stop taking them altogether because they cannot afford them, their conditions become acute and additional health issues arise. Medical crises result in much more expensive care in an emergency department or worse. They do not seek care and they die avoidable and undignified deaths. Medicaid is our largest payer. Losing 6,500 Medicaid patients represents a minimum $3 million annual loss for Optimus. On top of the years of stagnant 330 grant funding from the federal government and flat Medicaid reimbursements, this blow is unsustainable. It will force us to make painful choices, cutting programs, closing sites, and shrinking access precisely when demand for care will be the highest. Further changes proposed to the 340B program compound these threats. If manufacturers succeed in moving the 340B to a rebate model, Optimus will have to purchase drugs at commercial prices and wait months for reimbursement. The difference between the commercial price and the 340B ceiling price, assuming all inventory is sold. Payment of the commercial price up front significantly reduces the FQHC's cash flow that is already tight to begin with, and the FQHC risks unreimbursed losses if medications go unsold. The result is less revenue that we use for programming for our patients, less access to affordable medications, and higher costs for everyone. Revenue cuts directly erode our workforce. With a $3 million shortfall, Optimus will be forced to reduce staff. Even now, we struggle to recruit and retain primary care clinicians who can earn far more in hospitals than in community health. The shrinking national pool of primary care providers only heightens the competition. The uncertainty created by these policy changes has also shaken our staff. Dedicated employees, including employees who have given years to serving vulnerable communities and weathered tough times, are leaving for jobs that they see as more stable. When we lose staff, we lose the ability to see patients, and that means longer wait times for an appointment, reduced quality, and fewer services for people who need us most. And layered on top of these financial and access challenges are costly new administrative requirements, verifying immigration status and community engagement, and handling constant Medicaid redeterminations, each pulling staff away from patient care and forcing us to hire additional workers we cannot afford. The combined effect of these Medicaid changes and the executive orders will be devastating for Optimus, our patients, and our communities. Thousands will lose care. Millions of dollars will be stripped from Optimus, already stretched to the breaking point, and staff will leave. Sites will close, and our patients will pay the price, perhaps with their lives. I urge this committee to recognize the dangerous trajectory these policies set us on. FQHCs and Medicaid were created as a lifeline for vulnerable populations. We must protect access and strengthen and not weaken the safety net and ensure that FQHCs like Optimus can continue to fulfill our missions, providing affordable, accessible, quality healthcare for all. Thank you.
Thank you for your testimony. Last week, Representative Comey, Representative McCarthy-Vahey, and I had an opportunity to meet with Director Engels of HRSA, and we expressed to him what we've been hearing from the health centers in Connecticut, that the combination of the Republican budget bill and the executive order, I think of August 6th on Perora, were really existential threats to our health centers and could jeopardize the ability of you to continue to serve the people of Connecticut. In response, he said, well, hold on. He emphasized that he thought health centers were wonderful. And he's speaking, I assume, for HRSA, not for the entire administration. But he said good things about the work that you find people do every day to support the community, and said that he was going to work to make sure that additional guidance could come about how to comply with these new mandates, and that would be out hopefully shortly. He also expressed his support for the 340B program, at least insofar as it applies to health centers. I know that it's a much bigger question, but he expressed support for the program for your point. I guess I got a couple questions. One is, to the extent that you're not able to continue to serve your patients, where do they go? And second, if we could get some message to this administration about how to, what information would be helpful. Are there specific things that we should be asking them for? Because, I know the idea that, I'd like them to reconsider a lot of their policies, but I know that there's specific questions around Perora and some other things that we really need clarity on, so we know how you're going to be able to continue to operate.
I'll begin. So, one of the protections of federally qualified health centers have never collected any data related to documentation status. And so I think that's a protection that we need to continue moving forward. We serve all individuals who present for care, and so that's one of the asks that we continue with that. The earlier question that you had is where will these patients go? We are the trusted community providers, and regardless if individuals have coverage or not coverage, they will continue to present at our doors. So that is a piece that I think we need to really think about. Right now, health centers do have a portion of patients that are presenting that have no coverage. If that percentage continues to grow, we're going to be put in a position where we're just not going to be able to cover the cost of staffing, the cost of the facilities, and everything we need to run the services that we're running. So that's a piece that I think we need to consider. I don't believe individuals will not continue showing up. They will continue, but we're going to be put in a position of not having the resources to be able to continue delivering the capacity that we currently are offering across primary care, mental health, substance abuse, addiction treatment, and dental services.
I agree with what Sabrina has said, and I also wanted to add that where would they go if we can't serve them? And I think that that's a really important question, because I'm not sure where they would go. If Perora was to be in effect on September 11th, I'm not sure what we would do, because my understanding is if we were to provide the coverage for patients, that then we would be in violation of the 330, where we have to treat everybody regardless of their ability to pay. If we could jeopardize our participation in Medicare and Medicaid, we could violate the False Claims Act. I mean, we'd be abandoning patients because we would say we can't treat you. The possible claims of discrimination. So at every place we turn, that's a problem. And if we were not able to serve them, typically when we discharge a patient from our care, we provide 30 days worth of emergency care and prescriptions that they can have refilled. And we provide them a list of places where they could go to get care. I don't know where we could refer them to. I mean, AmeriCare's in Bridgeport, I don't even think is taking patients in anymore because they're overwhelmed. So, I think we're left to make some really tough decisions. And so I don't know what the answer to that question is. I think the answer is there is nowhere for them to go because the hospitals are going to be in the same position as we are. And if they do take them in, again, it's going to be at a much higher cost. I think if we were to ask Congress for anything is to roll back PROAR as it applies to health centers, because it just is inconsistent with our mission and our philosophy of care. So again, I think, that's one of the most difficult things for us right now and the most concerning.
Thank you. I guess I'm wondering if folks wind up in a hospital, at least hospitals are covered by EMTALA, and so they are, they'll be required to provide emergency care. But obviously, if we see a huge influx of people into our hospital friends, that's a huge cost for them and for the state as a whole and for everyone. The idea that we would be providing care in an emergency setting seems foolhardy. Why would we ever want to dump more people who don't need to go to an emergency room into an emergency room? Do you have any kind of arrangements right now with hospitals to divert folks who present in an emergency room but don't need an emergency level of care? Is that something that exists across the state, or how does that work?
Yeah, so Wheeler does have a number of partnerships with our local hospitals. When appropriate, for community-based care, individuals are connected to us. So a lot of it has to do with behavioral health. And so an individual may present with a behavioral health issue and concern, and we guarantee same-day open access. And the hospital systems know that, and they will say, you can present to Wheeler at this location, and they will see you today and can continue the medications for you. So that's a partnership we have with them, and it works because right now the majority of individuals who are presenting have some form of coverage. So that works today. What would that look like in a scenario where there's a high percentage of individuals with no coverage? And being able to accept and continue to deliver that care is really the big question.
Representative Dayton.
Thank you so much, Senator. Thank you for your testimony today. The work you do is so important. I'm going to follow on, I don't know if you were in the room when I asked the questions to Mairead Painter about the sort of effects on the workforce. And I know your staff that you hire are trained or have had associate's degrees, other sort of training. Have you all talked about the effects of the lack of student loan financing opportunities for people who want to get into the workforce? And I'm concerned about this being a huge barrier to your flow of new talent that comes to work with you. I know this isn't the higher ed committee, and I know they're having a separate hearing on September 9th. But while I have you here today, this is something that I'm thinking a lot about, because if you don't have the ability to hire great people, then we're not going to be able to serve our residents.
I think right now, one of the tools that really is a significant feeder to all of our workforce issues, and because we're a very strong behavioral health provider, psychiatric provider, primary care provider, we really cut across so many different disciplines. our largest feeder right now is our ability to have residents and our ability to have interns. And at any given point, we're just starting our new group at this within the last few weeks. We have about 46 individuals across a number of disciplines who work with Wheeler over the next year, who get to know us and get to know our patients, and that becomes our number one recruiting tool. Our ability to continue to expand that and to continue to grow that is really contingent on our ability to have a staff that can provide the supervision, the documentation, and all of the supports that are needed. The reimbursement program, I think, would be is a valuable tool. A valuable tool in particular for staff that we have that are currently working with us that may be interested in continuing their education and pursuing their RN from being a medical assistant, or continuing from going from a case manager to wanting to become a licensed clinician. So that would be the tool for us to continue to retain the staff to be with us as they pursue those. So anything we can do related to that area is definitely an area. And one of the pieces that to me is always very concerning is how many of our students, our residents, are clearly looking to leave the state once they complete their education. And so when it comes to retention and our ability to engage them and keep them in Connecticut, it's those loan repayment programs that can help us keep them here.
Got it. Thank you so much. The second question I have is regarding sort of data protection, and what are your entities doing to ensure that for the people that you serve, that their data is protected in case maybe some are undocumented or have other sort of differences in their immigration status. Thank you.
Okay, so we do not collect any information that in any which way would identify documentation status or non-status within our system. And so we don't have it, we don't collect it, we never have, and we hope that protection continues for us.
Great. Same question for your entity.
Similarly, we do not collect immigration status from our patients. We do function under HIPAA, so we do not provide any information to anybody without the appropriate HIPAA compliant authorizations. I know that we have heard from our patients that they were concerned because Medicaid had to provide some of that information, and some of the individuals who do have Medicaid benefits are undocumented, and that has caused them to stay home. So.
And then potentially come back later for emergency treatments that are probably more costly.
Yeah. And I mean, there's been a couple of incidences in Bridgeport and also in Stamford where we have received calls from our patients stating that they're not coming in because there is ICE activity either outside of our sites, or I think in Stamford a couple of weeks ago, they were, I think, waiting for people to get off of public transportation. And so.
Very concerning. Well, again, thank you so much for your testimonies today. It's really valuable for our committee. Thank you, Mr. and Mrs. Chair, Ms. Chair.
You're welcome. Thank you. Going to Representative Hughes, followed by Representative Shake.
Thank you, Madam Chair, and thank you both for your really clear-eyed testimonial today about the real life impacts. I didn't hear anybody talk about prior authorization and how that's impacting care. And I have heard about new, executive orders or whatever, bumping up prior authorization and, both Medicare, Medicaid. Can you talk a little bit about anticipating that, what that will do to the workforce that just wants to provide care to their patients versus administrative blockades?
I think that's along the same line as also as the redetermination. Currently, the staff that does the prior authorizations, we do not have that done by our licensed staff. We hire people that do that. In particular, it is around behavioral healthcare and some of the specialty services, where that's all that they do is prior authorizations. If that were to come into play and they had to have prior authorizations for all types of Medicaid, we would just be, again, hiring more people that we simply can't afford to hire because those are not, reimbursable positions. So with that, and then with the redeterminations, which we'll also have to hire more people to do, we just continue to, it's a strain on our revenue because, we're not going to get paid more to do it. So that's the problem. And without doing
it would essentially intentionally collapse the system. And I think that's the point, and that's what I wanted to get at, more evidence that this is
yes,
designed to collapse this care system that is so vital.
right. And, even if you were to underhire, for example, for lack of a better word, what's going to happen is things are going to fall through the cracks and you're not going to get paid because you won't have a prior authorization for that particular service. So it forces your hands into doing that.
Did you have anything to add to that?
The impact would be to some of our most critical services like medication-assisted treatment for opioid addiction, psychiatric services, behavioral health services, where our entire model is built on an open access. So Monday through Friday, no appointment needed. You walk in and we triage and we're able to get you started on medication-assisted treatment before you leave. Any pre-authorizations to that process will delay care. And we know, particularly for addiction services, for behavioral health, when someone has the courage to walk in and we're letting them know they need to come back without any care, come back to see if you're approved, and then we can begin care. There is no guarantee that individual will come back. And so just from a philosophy of treatment, we deliver immediate access, and that would really be a significant disadvantage to many of our patients and getting the care when they need it.
Thank you. And secondly, just to reiterate the question and point, it's not just protecting data, but it is protecting patients from being hunted by ICE and terrorized by, in some cases, illegal, vigilante masked characters. We've heard about Medicaid being breached. We've heard about our Social Security system already being breached. We don't know where that data is. I've had constituents who were going to the unemployment office to secure some, administration of their unemployment case and called by ICE. So we are not just asking about you protecting the data. We are asking how exposed all of our communities are now to being terrorized just for trying to access care.
One of the steps, which, we've never had to take, we've had to train our entire front desk staff on understanding what the rights are of our patients, what their rights are, and in the event there is presentation to any of our sites, what we can and cannot do, and what steps are needed to call legal and or other representation before letting anyone into our facilities. And not something that was part of our regular human resource training for our front desk representatives, but something that we had to take. And other steps that we've tried to take is ensuring that all of our facilities have labeling so that it's clearly designated which areas are confidential areas, which require different legal or different documentation to be presented in order to access. But those are the steps that we've had to take in a period of time where, we're completely stretched with resources, with more patients presenting for care, with workforce issues, yet we had to put additional resources to take those steps to try to protect our patients as much as possible.
Thank you for that. And Mr. Chair, just as we go into special session, looking to protect your care providers and your patients, is there anything we can do to strengthen those protections in this landscape?
Yeah, I think that if it were possible to have community health centers be off limits for ICE to be able to come in, and perhaps even have a certain amount of space in front of our building.
A buffer.
Yes, for them to be able to access.
I was going to say something very similar. Yeah.
Because currently they can come, I mean, we do the same thing. We've trained our front staff and we have signs as to, you cannot come anywhere beyond this, this entry. They can come in and they can come into our waiting room, but they can't access in the back. I think that's too close. And I also think that, it's just very threatening to patients, and it doesn't.
The whole boundary of the state is too close, but yes. Okay. Thank you, Mr. Chair.
And we've also had concerns from our providers. Yeah, so our providers, when looking at some of the language related to the executive orders, I've had providers ask, am I setting myself up personally for prosecution because I'm continuing to deliver care? It may be gender affirming care. It may be a number of other pieces, but providers are asking, am I opening myself up for liability? Yeah.
Thank you very much. Representative Shake, followed by Representative Fortier, followed by Representative Comey.
Thank you, Madam Chair. Thank you to both of you so much for being exceptional leaders. Before we even are in the situation that we're in right now. But I just, as a healthcare worker, as someone who, deeply cares about public health, community health, both organizations and through your leadership, of being able to break down barriers and increase accessibility for your patients and communities, really has, I think, kind of recreated the model or has raised the bar for neighboring states and what they're doing. So I just want to preface my gratitude to both of you and everyone who works, inside the CHCs and Optimus Healthcare. I have many constituents who utilize Optimus Healthcare because I'm in Stratford, but I also follow CHC of what's happening in other parts of the state a little bit more north from Stratford. My question in regards to the workforce, but when you have patients come in, what I heard from your testimony, if it's the initial intake and whether it's the nurse or whoever is there asking those questions, and they're asking about, do you have food insecurity? Are you safe at home? So leading into domestic violence concerns. Are you concerned with, paying your utility bills, or mental health and screening for depression, anxiety, all of those things, which in the healthcare world, we refer to as the social determinants of health, right? So when you, in the environment that we're living and working in now, are you able to capture, or is there a different way that you're identifying those patients or families that are meeting whatever the said criteria is? And it's because of the fear that we're living with right now because of what's happening. B, because, the food insecurity was already a major issue across the entire state, but in anticipation of what's coming and how they're going to be negatively impacted and further increasing that said person or family's risk. And is there documentation that is identified in that social determinants of health survey that's applied for a person or family that's linking it back to, what's happening at the federal level? Like, is there, if it's HR1, is there something that way in the data? And I know we talk about this a lot in healthcare where we don't refer to people as numbers. We offer them the dignity and respect that each person deserves, regardless of whatever their status is, whether it's food insecurity, documentation status, housing, right? We'll take care of everybody. But it is very helpful for us. And I think what all the numbers and information that both of you presented to us is very helpful. I'm going to go back and rewatch this part of the recording so that I'm better prepared at the next meeting. But if there's anything else that you think would be helpful for us as the legislature to help you now, and I heard from Senator Lesser and I think Representative Hughes, in trying to be your advocates, right? Because the intention of all of this is to collapse the entire system. So we are codependent on each other in trying to take care of people. So I don't think my question was very clear. If you have further recommendations and whatever your testimonies are, and I would just echo this and request it through my chairs, everybody's testimonies that are being submitted or whatever they're offering to bring today, if that can be shared with us so we can then review it, because you're pointing to information data. I really appreciate Karen, how you broke down into those 4 subsections of, it's like, this is how this is going to negatively impact how you guys do your jobs and how it impacts the communities. And then further down the line, which we kind of heard about, which they're going to end up either back at your facilities or they're going to be in the emergency room at the closest hospital. Or it might be a situation where nobody can help them. And then they're calling the police or someone's calling 911 because they're at risk of harming themselves, right? Without those facilities or resources.
I think something to consider is that the makeup of our workforce, because we do delve into the social determinants of health, and that can't be done by the clinicians because it would take too much time, and we need them to be focused on providing the care. So we have community health workers that do that work and connect them with the services that they need so that they are able to access healthcare and access any of the other services that they need. Of course, that comes at a cost. And so currently, our CHWs are covered under the money we get from PCMH Plus. So if that were to go away, so do our CHWs. I know that there was some talk about having CHW work reimbursed, and that would be very helpful because I think it's not just Optimus. Every federally qualified health center in the state uses community health workers, and they're critical. They're critical to the work we do. It's just not realistic to have that work placed on clinicians, even nurses and MAs that already have other work to be done, screening patients as they come in, doing the other work that needs to be done because it is time consuming. And so the community health worker is that point person that can do that work. So that would be my ask, is for that to be reimbursed.
The only other piece I would add, we do quite a bit of fundraising for an internal fund we call our Basic Needs Fund. And that is really a bridge fund that we use when a patient's coming in and says that they have not had a meal in 3 days. It is not helpful to begin the entitlement work that needs to happen to get them the long-term entitlements. So we dive into our own basic needs fund for that emergency, that gap, to be able to ensure patients have access to food, groceries. We've used even for something like a mattress. So we had a child, chronic asthma, trying to work with the child. And then we come to find out the child has a mattress that's been passed down for years after years, not the right mattress for the child, it adding to the asthma. So having flexibility to address some immediate emergent um, uh, um, basic needs as we work towards looking for the longer term entitlements. We're fortunate that we're able to raise dollars to do that. We're able to raise dollars today. I don't know what that's going to look like moving forward, but that's a critical need, a critical gap that we have within our continuum.
And I would also add that in what Sabrina is saying is the generosity of our staff, because I've heard that our staff will open up their purses and give them money, which I don't think that's a great idea, but they, feel so deeply for them that they do that. And we do have a food pantry where we're able to provide food for those that haven't eaten. And we always collect clothes and baby items that may be needed. So, and that's all done through fundraising from the staff. So.
Thank you. Already doing so much with so little. So thank you very much. Representative Fortier, followed by Representative Comey.
Thank you all and good afternoon. Can you hear me?
Yes, we can.
Okay. I want to thank both ladies.
Rep Fortier, you now froze. Maybe go off camera. Sometimes that helps.
For their great leadership, and especially Sabrina. Sabrina's facility in Bristol is in my district, and I can self-care. Wasn't going to talk numbers, but this time I do want to get to numbers a little. One of you said that you were going to lose possibly 6,500 patients eligibility. If for your organization statewide, do you have a sense of the number of people total that could lose coverage? And then can you translate that to numbers? What could we as a state do to, give you the money to cover those people? I'm not promising we can do that, but again, I'd be interested in that number. What would it take to cover the people that could potentially lose coverage?
Yeah, so at Optimus, we had estimated that the reduction would be about 6,500 patients, and some back of the envelope math would equal about $3 million in revenue a year that we would not be getting from those patients. In fact, if they continue to receive care at Optimus, perhaps they would be able to get onto the sliding fee. And so we would maybe reduce that somewhat, but probably not by much. So that does, like I said, the 6,500 patients translates into roughly $3 million, potentially more, but I tried to be on the conservative side.
Do either of you, I know you can't probably answer this now, but could you calculate that statewide for us and get back to us? Pooling all the community health centers together and giving us a basic number?
We probably could do that through the PCA. Yep. And like I said,
Perfect.
what's
Thank you.
difficult about
I think that would be helpful.
Yeah. What's a little bit difficult about it is the 6,500 is kind of an estimation on our part, because what we don't know is who's undocumented, because we don't know.
Sure.
So we have, made some assumptions about
Right.
particular groups of patients that may be on Medicaid and what that would result in. So what you'll get is probably our best estimate. But we can bring that back to the PCA.
Sure, that's perfect. Thank you.
Thank you. Representative Comey.
Thank you so much. I've been eagerly waiting. One of the things that we heard last week at the conference was about the focus on rural healthcare. And, you know, the discussion around mobile crisis, mobile health, mobile service delivery, I guess we call it, and serving the homeless and the veterans is a big part of your work. We also heard about community health workers and the important role that they play. And HR1 seems to be focusing on a lot of quality improvement measures, and there were some recommendations, I would say, that you consider thinking a little bit, outside the way we've always done things, and reclassifying the billing for the community health workers and calling them quality improvement, as opposed to, say, an administrative role that they play. So I did want to pass that on. There was a lot of emphasis about, just reframing some of the current practices and using it for potential outreach and some of the quality improvement things in the rural health that they're focusing on with the HR1 bill. So I was just wondering if you had any information on that, and how you envision being able to work into their focus on rural health.
I think we have some limitations in Connecticut regarding some of the rural health dollars that will be made available. While there are some areas of the state that may potentially qualify, the majority of Connecticut does not qualify for that. So that's something that we're certainly going to be taking a look at. With the community health workers, there are a number of states that for a number of years have had the opportunity to be reimbursed under their Medicaid programs for that level of care, for that service. Connecticut is not there yet, so we haven't had that opportunity. I know for myself, I'm pursuing grant after grant, either private or foundation grant, to be able to sustain the community health workers that I currently have. And that's difficult. That's difficult to go from a 1-year grant to a 12-year to an 18-month grant. Know, how I'm managing it across my system. But it's a resource that I think could be really helpful for us as we continue to think about a lot of the work that's going to need to happen with the Medicaid changes in getting information out to patients, to communities, educating, and to help motivate and support individuals in pursuing the requirements they're going to have to show forward. So that's an area that I'm hoping Connecticut can begin to think about how we're able to build that into our system.
And I would just wanted to have you comment for a minute on the population of the homeless that you serve, and any veterans that may or may not be served by your health centers.
Yeah. So our health center, we do have 2 mobile vans. The majority of our mobile health services are in homeless shelters and or other communities where we know there's a high percentage of individuals who are homeless. It is the staff that I have do that work are absolutely amazing. There are instances where they will need to go out for months on a weekly basis to build trust with individuals who have so So lack of trust in health and services. And so there are instances where we are providing care right in the van, in the community for a period of time until we build that trust, and then we can engage the patient to come on site where we can give them a full array of other services. There are other instances where we will continue to provide the care on our mobile unit, and that's the only care the individual is willing. But the we're going to continue that work. That's critical work. But once again, I think the mobile gives us more opportunity to do additional outreach and engagement within the community. We all have great facilities, but we know there are patients that will not walk through our doors, and we need to figure out other ways that we get to individuals.
We do not have mobile services, but we do have sites in homeless shelters in Stanford. And then we also partner with other community organizations, community-based organizations that serve the unhoused population or homeless population, and have a referral service so that we can see them at some of our regular sites.
Thank you very much. Thank you for the work you're doing, and thank you for all the amazing suggestions. We really appreciate you being here and for your time.
Thank you.
Next, we'll bring, or there on Zoom, Connecticut Institute for Refugees and Immigrants. We have someone, we don't have Bonnie, right? Sorry, I'm missing the name.
We have
Chris? Okay. Hi, Chris. Thank you for being here. Go right ahead.
Thank you so much for your time. I apologize for someone was going to be with me this morning and couldn't make it. So thank you so much for the opportunity to be here, Representative Gilchrist and Senator Lesser and others who gathered here today. I will speak directly to the impact on refugees we work with, as well as victims, foreign-born victims of crime, especially those who are survivors of sex and labor trafficking. Just for context, last calendar year, our organization served 5,700 refugees and immigrants here in Connecticut across 5 offices. This year through June, we've already served 4,135 refugee and immigrant clients. So the need remains absolutely essential. You may know that one out of every 6 people living in Connecticut are foreign-born. 1 out of every 3 Connecticut children live with a parent who is foreign-born. So we are talking about hundreds of thousands of people in our state. Regarding refugees, last year we served 1,569 refugees. Through June of this year, we've already exceeded that. We've served 1,696 refugees. And of course, our goal for refugees in the state is self-sufficiency, where they do not have to rely on assistance, but it is absolutely essential at the beginning of their journey. So just some real world stories from our Chief Program Officer. Over the last few months, some of the clients we've welcomed include 2 children with cerebral palsy. These are refugee clients. A single mother with multiple sclerosis, a single mother with epilepsy and severe burns, and a 7-year-old girl with a blood disorder causing her to need biweekly blood transfusions. Each of these individuals' needs for acute care were extreme. They were necessary for basic survival. And generally speaking, refugees who arrive in the state have no source of income when they arrive. We do workforce training. We try to get them employed as quickly as possible. But upon arrival, they have no resources, so there's no way for them to pay for out-of-pocket treatment or medication until they start working. Earlier, someone mentioned pregnancies and maternal care. For our refugee clients, the average cost of delivery is between $13,000 and $22,000 as of last month. And that is a delivery without any complications and does not include the cost of pre-delivery care and service for the newborn, including vaccinations and required checkups. We have had several mothers arrive who are 7 to 8 months pregnant. Some arrive without the father of their children, whose case was kept separate and who's left behind in the refugee camp without access to Medicaid. These mothers would not be able to afford a safe delivery, which would put their lives and the lives of their children at risk. And again, for context, refugees arrive in this country and in the state with instant debt. They have to pay back the cost of their flight to the United States to the International Organization for Migration. The average cost of one ticket is $800. So a family of 6 coming from a refugee camp in Tanzania, as happened recently, owed $6,070. Compiling that debt with medical expenses plus the rising cost of housing in the United States, these new families within their first year would have no opportunity to establish a successful, stable future for themselves and for their families. And some words about survivors of trafficking who are foreign born that we work with. Again, for context, last year we served 292 survivors of trafficking. These are minors and adults, as well as foreign born victims of crime like domestic violence. So to date this year, we've already served 172. The director of Project Rescue, which is our work with trafficking victims and foreign-born victims of other crime, reports that the loss of food assistance represented by this bill would result in victims who are in recovery facing food insecurity, making them more vulnerable to re-exploitation or forced to return to unsafe environments just to meet their basic needs. Survivors in recovery often rely on food stamps as their only reliable source of nutrition, and they would be forced to choose between paying for food or other necessities. The loss of health insurance like Medicaid would result in victims no longer having consistent access to primary and emergency care, mental health services, dental care, medication, and ongoing treatments, often neglected during exploitation, forcing these survivors to delay care, worsening both physical and trauma recovery. These would be some of the many challenges faced by our clients, refugee as well as trafficking victims. And then, of course, we currently are serving over 3,000 immigrant clients who are pursuing a variety of legal issues to secure citizenship, work authorization, family reunification, and the lot.
Thank you so much, Chris, for being here. I find most of what's in HR1 cruel. And this area is particularly cruel, maybe because of my background on the Trafficking in Persons Council. Could you just let folks know what it takes for someone immigrating to the United States to be deemed a victim of human trafficking?
Yeah, it is an unnecessarily difficult process. And I mean, one of the key parts of that is the preparation of a victim statement. So, I mean, first they have to take the risk of disclosing to some person that they believe they may be a victim of a crime, which is often very difficult for them to do because they fear retribution by those who have victimized them. And so often the clients who come to us prepared to make a victim statement have been suffering for months and sometimes years, both outside the country and within the country. Once that statement is taken, which is a long process and a difficult one for them to do emotionally, and as well as for other reasons, then there is the process of trying to get specific legal status that indicates that they are indeed a verified victim of a crime of trafficking or domestic abuse, and that gives them a particular legal standing within the country and then allows them to move forward with other things like work authorization and a number of other things. So it is quite a difficult thing, and of course this conversation is largely taking into account adults. For minor victims of trafficking and other crimes, it is significantly worse.
Thank you for detailing that, because I think there will be, if there hasn't been misinformation already, I would think some misinformation is going to be put out there. And I just wanted folks to know that this is a pretty arduous process that we should improve for someone to actually get the status of what they experienced as a victim. And then to take away their food benefit just seems bizarrely cruel. So thank you. Representative Hughes, followed by Senator Lesser.
Thank you, Madam Chair, and thank you, Chris. Great to have you here today to round out this, again, dire impact. Working with the refugees that come here, especially from the refugee camps, can you give us an idea about how many are vulnerable now, especially to sexual assault, to the weaponization of as victims of war and economic, refugees, how they're much more vulnerable, and what the percentage is, whether they declare and make a victim statement or not about being survivors of sexual harm.
I appreciate the question. I mean, there's approximately 24,000 cases of trafficking victims that are known in the United States. Of course, many additional victims that are not identified. Over 80% of those 24,000 are refugees and immigrants. They are the most likely population to be victimized by trafficking, because they have few resources, they have few connections in the current climate. They are afraid to make these victim statements known for fear of deportation or other retribution from ICE or others. So we're talking about a population that makes up the bulk of trafficking victims. And here in Connecticut, there are at least 300 cases of youth trafficking each year in Connecticut. And the vast majority of those are foreign-born as well.
Thank you for that. And just a clarification. So how you said at the beginning of your testimony how many you served, and the number has gone up this year at the end of June. Can you give us an idea of that? And again, how many of those are women and children? And then what is your estimated percent that how many may be vulnerable to not just sexual trafficking, but assault?
Yeah, well, I mean, so looking at the 2024 data, we served 130 minor survivors of trafficking. 105 of those were unaccompanied minors. And then the rest of the 292 were adult survivors of trafficking or of other crimes like domestic abuse. So yeah, so those are high numbers, and the unaccompanied minors is obviously a particularly vulnerable group of people. And of course, we've already seen multiple attempts by the current administration to defund legal
Actions.
representation for unaccompanied minors. And my sense is there may be a hearing on victim services, and we certainly have a lot to share there as well.
Thank you. Thank you so much, Madam Chair.
Thank you. Senator Lester, followed by Representative Dathan.
Thank you. And thank you for your testimony. You know, I'm struggling with this. I'm very conscious that, you know, the only reason I'm here is because of my grandmother, who was a refugee. And as a 14-year-old, her family had to turn to human traffickers, human smugglers to get them across a border. And if they hadn't done that, they would have been killed. And the rest of the family were killed. And each refugee in Connecticut has their own story, their own personal trauma. They came here seeking freedom and life. And it's cruel to go after the most vulnerable people in the world, to take away their ability to survive in this country, their food and their healthcare. Just a question though, because I keep hearing from folks who believe that this federal legislation is only aimed at folks who are here unlawfully. Is it unlawful to be a refugee or an asylum seeker in Connecticut in the United States?
Absolutely not. It is not. And every refugee client that comes to us through USCRI is one of the most vetted individuals to enter the country that is possible. That they arrive at LaGuardia or JFK with legal standing. And then asylum seekers, I mean, that is a clear legal standing in this country, and it's unconscionable by a tangential connection here to see the administration's effort to remove things like temporary status, secure legal standing in the country for people who have every reason to be in this country as an asylee or a parolee, and to have that status removed is unconscionable.
Thank you.
Thank you, Senator. Representative Dathan.
Thank you so much. And thank you so much for your presentation. It's really disappointing to hear this. We had a hearing in government oversight last week, and the commissioner of DCF indicated in that hearing that we have an epidemic of human trafficking in our state. And we all kind of knew there was a really big problem, but really magnifying this is important so that people understand how many people are affected by this. You put together some numbers. I'm hoping that you can document that and share it with our administrator, Brianne Clifton, so that we can have these numbers to hand, and any other sort of sources, so that we can get an understanding a little bit better. And these are people kind of under the radar, so to speak. And one of my questions about last week is, how do we ensure that we are capturing everybody and getting the folks that they need services? And your testimony today has highlighted that there are a number of folks out there that are not captured in the DCS system for one reason or another, because of potentially their immigration status and how they may, families may not want to come forward. So if you would share with those just data points that you reference, I'd greatly appreciate it. And again, thank you so much. And thank you, Madam Chair.
I sure will. Thank you.
Thank you. Thank you so much for your patience today, and for the work you're doing, and for letting us know how this is impacting you. Thank you.
Thank you.
Next, we will hear from Planned Parenthood of Southern New England, Gretchen Raffa and Aaron Gaudreau. And then Mark Schaefer, thank you so much. Hanging in there. And thank you all for waiting and being here all day.
Well, we love hanging out with you. Senator Lesser, Representative Gilchrist, and honorable members of the Human Services Committee. My name is Gretchen Raffa, Chief Policy and Advocacy Officer, and I'm joined by my colleague, Aaron Gaudreau, General Counsel for Planned Parenthood of Southern New England. We thank you for the opportunity to testify and provide comments on the harmful impact of HR1 on Planned Parenthood patients in the communities we serve. Planned Parenthood believes all people should have access to quality, affordable, and compassionate healthcare as a basic human right, regardless of who you are, where you live, your income, if you have health insurance or your immigration status. Planned Parenthood plays an indispensable and irreplaceable role in our healthcare system in our state. For many communities, Planned Parenthood health centers are the sole provider of sexual and reproductive health care. PPS&E is focused on health equity, serving everyone that needs care regardless of who they are, again, regardless of their insurance type, and regardless of their ability to pay. Over 52,000 patients came to PPS&E health centers across the state. We have 14 health centers across the state or use telehealth for their care. And about 46%, nearly 25,000 of those patients were insured by Husky Health to cover their services. The majority of PPS&E patients identify as people of color. 85% of patients in Connecticut identify as women, and 90% of patients are over the age of 20. 88% of the care delivered is preventative or gynecological care, and 12% is abortion care. The Trump administration and Congress's intentional attempt to defund Planned Parenthood through the federal reconciliation law is an unconstitutional attack that will harm the 1.1 million patients with Medicaid who come to Planned Parenthood health centers across the country every year. It's also an attack on this country's already broken healthcare system. We know what will happen if this provision of this cruel law is allowed to take effect again. The consequences would be catastrophic. Cancers go undetected, STIs go untreated, and patients won't get the birth control or the abortion care they need to plan their families and their futures. The consequences would be nothing short of a public health crisis. You've heard this multiple times today, and you've said it. The cruelty is absolutely the point. Let's call this provision what it is. It's a backdoor abortion ban. Why are we calling it a backdoor abortion ban? Because over 90% of the Planned Parenthood health centers at risk of closures are located in states where abortion remains legal and protected. These closures could eliminate a quarter of all abortion providers nationwide and threaten to shut down half of Planned Parenthood health centers that provide abortion services, including right here in our region. This is a naked attempt to leverage the government's control over funds to punish Planned Parenthood because, where legal, Planned Parenthood health centers proudly fight for and provide abortion care. It's also important to note that with very rare exceptions, people with Medicaid coverage already can't use federal funding for abortion because of an unfair, racist, and discriminatory federal policy called the Hyde Amendment. Because of the unreliability of the U.S. healthcare system and the abortion access crisis created by state bans and an administration and Congress hostile to sexual and reproductive healthcare, some Planned Parenthood members have already been forced to make shifts, reduce services, and even have to close some health centers in this country. The people who will pay for this, and with their health and with their most basic freedoms to control their bodies and are most harmed, are the communities Planned Parenthood serves. Women, Black and Latino patients, LGBTQ plus people, immigrants, young people, and people who live in rural and medically underserved areas. As you might know, Planned Parenthood Federation of America, on behalf of all of its members, including PPS&E, filed a lawsuit challenging the federal reconciliation law that, again, unconstitutionally defunds Planned Parenthood. I'm going to turn it over to my colleague, Aaron, who will provide an update on the legal landscape and the impact HR1 is having on Planned Parenthood of Southern New England, as well as other threats facing us from the federal government right now.
Good afternoon, committee. As Gretchen said, my name is Erin Gaudreau. I am incredibly honored to be both a former patient of PPSNE and to get to come back now in the role of general counsel during this unprecedented time in our organization's history. While Planned Parenthood is not explicitly named in HR1, make no mistake that it was written specifically to target our organization. Using the threshold of $800 million in Medicaid payments during fiscal year 2023 ensures that the overwhelming majority of entities impacted by this defund provision are Planned Parenthood health centers. It is my understanding that the current scope of non-Planned Parenthood providers nationwide impacted by this provision is less than 3. In comparison, there are just under 50 Planned Parenthood affiliates nationwide. Even though this legislation has a 10-1 date of determination of prohibited entities, the defund provision went into effect immediately. It doesn't take being a legal scholar to see that the intention was to financially handicap Planned Parenthood organizations as quickly as possible and force us to make difficult decisions around the services we provide to our patients. Thankfully, a preliminary injunction was granted on July 28th for all Planned Parenthood affiliates, prohibiting retroactive and prospective enforcement on HR1 until the case is decided. A stay motion was filed by the Department of Justice in both the District Court and First Circuit. There was a lot of press that the First Circuit did deny that motion, but it was really just down to a matter of ripeness. They did not believe that it was their role to rule on that appeal since the District Court still had not ruled. The District Court did deny that stay last Friday, but the Department of Justice has already filed yet another appeal with the First Circuit with the goal, this has been made public knowledge, that they would like to have a fast decision to ultimately have a decision from SCOTUS. So there is already a plan to appeal to the Supreme Court prior to that 10-1 implementation date. At PPSNE, while we were encouraged by the District Court's ruling issuing a preliminary injunction and denying that stay, this is a key victory, but a temporary one. It can change at any time. The First Circuit SCOTUS could choose to side with the Department of Justice, and at that point, HR1 comes fully back into effect. But as of right now, as this case continues, patients across the country can still use Medicaid insurance, including our patients who use Husky Health here in Connecticut, to get care at their trusted Planned Parenthood health centers with their providers. And our health centers can be provided for the essential services that we are providing to our patients. We are going to continue to fight this cruel law to ensure that everyone can get access to the health care that they need when they need it. As of today, with the preliminary injunction in place, PPSNE can still bill the state and federal government for the essential services we provide, and we have resumed that billing as of August 21st. Since July 5th, we held just over 3,700 claims for services totaling just under $3 million. That is $3 million in claims that we would have lost out on had the defund provision been allowed to stand. As Gretchen noted earlier, we have served over 25,000 Husky patients in the last fiscal year. It would be up to the state to figure out how much, if any, of the matching funds we get from the federal government they would be able to backfill if the defund provision were allowed to stand. Any backfill of less than the full amount would result in lost revenue for PPSNE and would impact our ability to continue to serve our patients in the way that they are accustomed. While we are lucky to operate in a state like Connecticut that already provides state funding for abortion services, it is our understanding through the many conversations we have had that the state systems are not currently set up for claims outside of abortion to be submitted for state-only funds. On top of the awfulness of HR1, we are also dealing with having our Title X funds withheld as well. On March 31st, we were notified that our funds that were due to be released on April 1st, you're not hearing wrong, the very next day, were going to be withheld due to illegal DEI being practiced by PPSNE and other PPSNE affiliates under President Trump's executive order concerning DEI. Since 1970, when it was enacted with bipartisan support, Title X has helped people who couldn't otherwise afford reproductive health and family planning services get the care that they need. This is a withholding of $1.9 million in Title X funds to our organization. There is a lawsuit that is currently being led by the National Family Planning and Reproductive Health Association, or NFRA. There are 9 Planned Parenthood entities, including PPSNE, that are direct grantees of Title X. As of today, no Planned Parenthood affiliate has had its funding restored, and the only entities having their funding still withheld are Planned Parenthood affiliates. The judge in this lawsuit asked for a joint status report last Friday. The Department of Justice noted that HHS is still reviewing the records that were provided to them as part of this investigation. If we are removed from Title 10, that impacts our ability to participate in 340B, especially with the 318 grant year ending this December and no notice by the CDC of a grant award for the period beginning January 1st as of this time. Title 10 is also one of the programs impacted by PROWARA. Nonprofits are currently not provided or not required, pardon me, to check immigration status. PPSNE does not. Confusingly, while Title 10 has been added to the programs that you do have to now check immigration status on, the language around nonprofits not being required to check immigration status remains, leaving us in conflict and uncertainty as to what exactly our obligations would remain to be under Title 10. In addition to this investigation under Title 10, the DEI executive order has led us to having to evaluate programs that make PPSNE not only a safe space for our patients to receive care, but a safe place for our employees to work, especially those who belong to groups that are being specifically and unfairly targeted by this administration. Under President Trump's executive order, bizarrely defining minors as now under the age of 18, we now have concerns as to whether care that we provide to those who are legal adults between the ages of 18 and 19 are able to be submitted for federal Medicaid reimbursement. Additionally, with 2 major hospitals in Connecticut announcing the termination for their gender-affirming care programs for minors, we are receiving a heartbreaking amount of outreach from parents and patients about where they can go to continue to get the care they or their child needs. Additionally, there is a separate rulemaking process pursuant to an additional executive order that would impact eligibility for public service loan forgiveness. Under this proposed rule, the education secretary could exclude employees engaging in activities deemed to have a substantially illegal purpose. An example of this would include aiding undocumented immigrants. Several hospitals have already noted that they have concerns about this due to the requirement that they provide emergency care to all, regardless of immigration status. And we share similar concerns. This would potentially disqualify our employees from PSLF. As I'm sure you know, nonprofits rely on public service loan forgiveness programs substantially because we cannot pay what private sector can pay, and that is a great benefit that we are able to offer. That rule is still under review and open to public comment. However, it is being noted that it could be used by this administration to punish those who work for nonprofits whose missions with which they do not align. With that being said, I'm going to turn it back to Gretchen for some final comments.
So the majority of Planned Parenthood patients pay for their care using Medicaid or other federal and state programs for uninsured patients. As you all know, Planned Parenthood of Southern New England is a safety net provider that reduces the burden on the healthcare system in our state, offering critical preventative and therapeutic health services and educational programs that address systemic and structural inequities, but without the buffers that other safety net providers have. Any funding that PPSNE receives federally is connected to our role as a safety net provider for preventative health care services only. Whether Congress defunds Planned Parenthood health centers for 1 year or 10, the impact is the same. Defunding will exacerbate the chaos of our country's already fragile reproductive health care infrastructure and disrupt access to birth control, cancer screenings, and other essential preventative sexual and reproductive health care services across the United States, and will actually cost the taxpayers money. No other provider in this state can easily fill the gap, or across the country. No other provider across the country can fill the gap if Planned Parenthood is shut down, according to research done by the Guttmacher Institute. In 9 states, including Connecticut, federally qualified health centers and other publicly supported clinics would need to increase their caseloads by more than 100% to provide care for patients currently served by Planned Parenthood. What makes this situation even more perilous is that FQHCs themselves are under attack by the administration, as you heard earlier today, and we all know, even if they could take on our current caseload. And we already know what happens to communities when politicians defund Planned Parenthood, causing health centers in communities to shut down. For example, in Indiana, defunding led to an HIV epidemic. In Texas, it led to tens of thousands of women not getting care. And in Iowa, it caused a spike in sexually transmitted infections and an 86% decrease in patients being served in Iowa. We cannot let those public health crises happen in Connecticut, where we know that access to reproductive health care is critical to building healthier communities. And we have seen our state have to be a beacon of hope as we've cared for patients who had to leave their home state to access essential care that is banned in their home state. PPSNE is facing the most uncertain 4 years of our history. The fact is the provision of HR1 to defund Planned Parenthood will place immense strain on PPS&E's current operations on top of the loss of almost $2 million in the Title X family planning funding that we used to receive, as Aaron noted. While at the same time, we're contending with the same skyrocketing costs faced by all healthcare providers. Connecticut Medicaid is Planned Parenthood of Southern New England's single largest payer, making up 50% of our payer mix. Overall, Connecticut Medicaid made up 27% of PPS&E's total revenue in FY25. Unlike private practices, we have little ability to offset low Medicaid rates with higher private insurance rates because of our service mix, which is almost 90% preventative services, and without high margin services to offset those losses. There are serious operational pressures that are threatening our ability to continue to meet the needs of our patients and communities, and we want to make clear that access to reproductive health care remains vulnerable in Connecticut despite having such strong laws protecting this care. These efforts by the federal administration and Congress will be devastating to patients in the country's already broken healthcare system, and it will block patients who depend on public healthcare funds from getting the care they need from their trusted provider at Planned Parenthood. Their choice of provider will be stripped from patients. Despite these challenges, our priority at PPS&A remains the health and well-being of the communities we serve. Again, we're a trusted, expert healthcare provider, and the American people overwhelmingly oppose efforts to cut funding to Planned Parenthood health centers. We're going to continue to work with our elected leaders to ensure that PPS&E has the necessary funding to be here for our patients today, tomorrow, and for years to come. We thank the administration and the General Assembly for including an increase in Medicaid reimbursement rates in the state budget for preventative services only this year. And we're going to continue to fight this cruel law on the federal level. For more than a century, Planned Parenthood has been dedicated to providing people with care and resources they need. And for just as long, unfortunately, we have been facing endless attacks and setbacks, but we always keep fighting. Access to sexual and reproductive health care is essential to being able to control your own body and plan your future. Basic freedoms that we all should have in this country. Defunding is an attempt by lawmakers to make Planned Parenthood stop caring for patients and stop caring about reproductive freedom. But the care continues no matter what. Our patients, our communities, and our providers in Connecticut are counting on us, and we're not going to let them down. Planned Parenthood is not going anywhere.
Thank you so much. And yeah, it seems like there hasn't been a year without an attack. So thank you for all the work you've done and continue to do. When do we have a date? Is it expected that this injunction, if I'm using the right terms, would make its way to the Supreme Court?
The stay motion, great question. The First Circuit has to rule on it. Like I mentioned, the Department of Justice has asked that they move swiftly. So that way, if the ruling is not in their favor, and honestly, if the ruling's not in our favor, then we could appeal to the Supreme Court as quickly as possible.
Okay.
Prior to that October 1st date.
Okay, prior to October 1st. Can you I know I've had a conversation about what took place in Texas. Can you explain what went on there and what the ramifications could be here?
Absolutely. So there's a law called the False Claims Act, and it is meant to weed out abuse of federal programs. And our affiliate in Greater Texas is currently under investigation for violating the FCA, but not for the reason you might think. They were removed from the state's Medicaid program. They had an injunction put into place similar to what we are experiencing now. They continue to provide services for their patients during that time. Ultimately, the injunction was stayed, but the allegation is that Planned Parenthood of Greater Texas should have paid back the money that they received during the time that the injunction was in place, and that they should have had actual notice that that was expected of them, because that is one of the requirements under the FCA, that you are knowingly defrauding the government. What makes this case even more concerning is the FCA has a minimum statutory damages provision applied to it. And the really novel part of this case is that they are trying to allege that each false Medicaid claim, false in heavy air quotes, that was submitted is in and of itself a false claim. So they are all subject to the statutory minimum rather than being treated as one particular instance. Between that and the treble damages requirements under the FCA, which is 3x of damages, if the lawsuit does not go in favor of Planned Parenthood of Greater Texas, I believe the damages are estimated to be well into the millions of dollars. And that is part of why we were holding our claims for so long after the preliminary injunction went through while we were trying to debate our own FCA risk.
And just to clarify, it's all three affiliates in Texas.
All three affiliates.
Yeah.
Thank you for that
Yeah,
clarification,
sorry.
Gretchen.
Thank you. Senator Lesser?
Okay, thank you. There's a lot of a lot to process. Thank you both for your testimony. Just a couple of questions. One, I heard you, Attorney Goodrow, talk about participation in the federal 340B program, which you said will be jeopardized by participation in Title 10. Now, I note that some states, and we don't normally, especially when we talk about Planned Parenthood, look to Arkansas or Oklahoma as model states, but those states have passed state statutes compelling participation in 340B as a way of shoring up their providers. And I'm just curious if you have thoughts about Connecticut potentially doing that. I know there have been sort of prior to all of this, there were some questions about limitations on contract pharmacies and whatnot. And I was curious if you'd looked at those statutes and thought that that might have some value here if your 340B status might be jeopardized.
I have not had a chance to review them yet, but I sure will now. But I think anything we can do to maintain our eligibility in the 340B program is not only important, but critical for the services that we provide for our patients, and allowing us to have the opportunity to provide the services that we do for the amount of patients that we do.
And obviously you both mentioned this, but Connecticut has had a long practice of providing, thanks to the federal government's wisdom and the Hyde Amendment, has been using state-only funds to provide support for certain services provided by Planned Parenthood. And we do receive a Medicaid match for other services provided by Planned Parenthood. How complicated is it to simply move funding over from federal to non-federal? You mentioned there were some technical questions with that, but my question is also just, do we need, assuming the feds are able to prevail in their attempt to defund you, are we able to, do we have to do anything, or does that funding somehow continue if we say that Connecticut intends to continue to provide those services to our residents using state-only funds? Is that something that can automatically happen, or do we have to move something over, and how complicated would that be? Just logistically.
Yeah, I will, I'll start, and then Aaron, you can jump in, of course. And I know Senator Lesser, you and I have talked about 340B pricing, and it's incredibly important, as our status is at huge risk. So anything the state can do to protect that is essential for us. So I would say one of the other things that I think is important that you were mentioning too is that the threat to the defunding is about the preventative services. And I don't think I said this out loud, but it's a 90-10 federal match. So it's a really, a benefit to the state for the 90% match. And what we have been asking of this administration is to figure out how they could, in worst case scenario, this provision is in effect, step in and make up the loss of those federal dollars. So last year, that would be about 7.6 million for non-abortion services, which was eligible for the 90-10 match. And from our understanding, there might have to be some sort of a system set up so that the data is not mixed with federal data.
Correct. It's my understanding from the conversations that we've had that it is an IT sort of issue on the back end. I'll be honest, my husband's a software developer and I've absorbed none of that knowledge during our marriage. But it is something that would have to be done on the IT sort of back end, because the concern is obviously if we are inadvertently paid with commingled dollars at some point, that could open up liability for the state.
Yeah, but a 90-10 split is a rough. That's a tough nut to crack, but let's look at the dollars and see what's so good.
Yeah.
Just one last question. I'm breaking the rules. Third question. We recently passed, strengthened our state's shield law, went into effect July 1st. I'm curious if there are any, one of the, we were talking to some hospitals that are affected. It seems that there's a loophole where we didn't cover potential federal criminal actions. We're only looking at civil. And I'm just curious if there's specific additional considerations that Planned Parenthood has for potential additional changes to our shield law in light of the federal budget or other recent federal actions.
I will jump in to say we are working with all of you, our legislative champions, to continue to strengthen our shield law. We did make some we've strengthened it in the last session. I think there are opportunities to continue looking at what other states are doing, including the telehealth protection and other ways to ensure the safety of data and security of data for patients and providers as well.
Thank you. Sounds like a conversation.
Yes.
Is happening.
And we're at 2:47, so the 2-question rule was out the window hours ago.
Yeah.
Representative Hughes, followed by Representative Shake.
Thank you. Thank you both so much. I just wanted to come back to something that I know we've all heard from our constituents and our families that are devastated by the letters that they receive from hospitals of ceasing gender affirming care for their young beloveds. And they are frantic, of course, about how to continue on their journey with qualified professional providers. So I'd like to hear a little bit more about that from you all and put it on the record for our families that are just so distraught and thinking about leaving the country.
Yeah. Well, Planned Parenthood of Southern New England is here to provide gender affirming hormone therapy for anyone 18 and over. We are working with our, our coalition and community partners to ensure that patients get the care that they need. And we know that Anchor Health has stepped in to ensure that young people that have lost access to that care will be able to deliver that care. And again, asking the state to do everything we can to ensure that there is funding available for this critical life-saving and life-affirming healthcare. Reminding folks that gender affirming healthcare is reproductive healthcare, and an attack on gender affirming healthcare is an attack on people's reproductive healthcare as well. And we need the state to do everything we can to ensure that providers have the support and the security and protection to continue to deliver that care.
And to clarify, part of why those calls are so heartbreaking to receive is because we are not in a position to help right now. And we do have to refer them to other providers. But you can, like you referred to, you can just hear the desperation in their voices.
Thank you.
Thank you very much. Representative Dayton. I'm sorry, was it Shake?
I think Shake was next.
Sorry, Representative Shake.
Thank you, Madam Chair. Thank you both for all the information that you shared with us today about all the life-saving services, healthcare services that Planned Parenthood has provided for patients here in this state. Similar to what I asked the Community Health Center and Optimus Healthcare, in the event that you don't have the funding that you need, and then the ability for patients to access the care that they need is out of reach for them because they've been, kicked off of Medicaid and or they don't meet whatever the set new future requirements are to be eligible and maintain those social safety net options. Where will your patients go to seek the care that they need?
Yeah.
Or in your opinion?
They will forgo care or end up in our hospital emergency rooms. As I stated, federally qualified health centers and other public health community health centers cannot fill this gap. People will lose access to care. Cancers will go undetected. Sexually transmitted infections will go untreated. People can't get the access to the birth control and abortion care. They will lose access to essential care. And if again, the cruelty is absolutely the point, because if we believe healthcare is a human right in this state, and I've heard our elected leaders say that over and over again, then we will ensure that Planned Parenthood of Southern New England and other safety net providers have the critical funding and resources we need to continue delivering care. Those 52,000 patients, I am a proud Planned Parenthood patient myself, do not all have options to go elsewhere. Some of us do, not everyone does. And for Planned Parenthood, we see patients, again, regardless of the ability to pay. So we depend on state and federal public funding dollars to ensure that patients can get affordable care, and sometimes at no cost to the patient.
Thank you. So would you then agree that with HR1 and other executive orders that have come out of the White House, that people are in general, right, are especially in our vulnerable populations, that they will now be sicker, that they will die sooner, and that it will just lead to a plethora or it's like a perpetual bad, fatal, negative outcomes, not just for the people who are not able to then access their care, but for their families, for the places that they work, the places that they go to worship, our communities as a whole. I really appreciate all the information. And again, same request, whatever your testimonies are, if you could send them to the chairs and to our administrator so that we could then refer back to them. It's very helpful. And thank you for all the work that you do.
Thank you. And we can't reiterate enough, we are the safety net, right? There's no net after us. That's why we need the state to do everything they can.
Thank you. Representative Dathan?
Thank you so much, and thank you for your patience today. It's been a long day. I know other folks have talked about like data protections, and one of the things that you highlighted in your testimony is that there could be issues with maybe serving the undocumented community. Within your sort of patient intake forms, do you ask patients about their immigration status?
No, we do not.
Okay. So again, you wouldn't know if someone is or someone is not. There are all sorts of HIPAA rules and things like that, which do protect patients. But we know these times have been a little different, and I myself have huge concerns about the protection of data for many reasons, for domestic violence survivors, for people who might be undocumented, other people who might be in a coercive control relationship and not able to get the care that they need. And those folks, as well as so many other folks in our state, I've been a patient of Planned Parenthood in the past and appreciate all the work that you do. And so just continue to let us know in your voices, and have your people that support you come out and tell us why the work that you do is so important, because we need every voice now. That's all. Thank you very much, Madam Chair.
Thank you so much. Thank you both for being here and for the information and for the work you do in these times. Thank you.
Thank you. Thanks, everyone.
And last but not least, Mark Schaefer from the Connecticut Hospital Association. Thank you for your patience today. So in front of you, the button, you can use that one.
That's okay?
Yep.
Okay. So thanks to all of you for spending all this so much time focused on these really broad and diverse impacts of HR1 to patients, to providers, and to communities. What I'm inevitably at the tail end, some of what I say is going to be a little repetitious, but I'll keep my comments brief so that there's time for any questions you have. When the main focus of HR1 has been the reductions in Medicaid eligibility, but there are also reductions in Medicare eligibility, and then there are non-HR1, as you've heard, threats to participation in the exchange. And there are what both my family planning colleagues and FQHCs have referenced are the Perora-based rule changes that could fundamentally affect some individuals from being able to get get care where they usually get it in their communities. So when people lose health care coverage or access, they often avoid or delay seeking care. They may not get early care or even the timely care for a condition. They may not get their prescription medications filled. And this can make manageable health problems like high blood pressure or diabetes or infections become much more serious over time. Without coverage or access, people are more likely to go to hospital emergency departments, which a number of people have referenced. They'll do this for routine or urgent care, for which they might otherwise have gone to a community provider. They will also, in some cases, wait until their conditions are so serious they're emergencies. And it's at that moment that they too will turn to emergency departments, which are often the only place individuals can receive care regardless of ability to pay. And with the Perora changes, there are some folks who can't, even for non-emergency, won't be able to go to FQHCs. Literally the only place they'll be able to go is emergency departments. At that point, illnesses will be more advanced, will require more intensive and more effective, expensive treatment. There will be very negative consequences for the individuals who experience this, and they may end up with hospital admissions as well. The consequence to hospitals is that they'll end up providing more uncompensated care, that is, care for which they're not paid. This is on top of the substantial $2.8 billion in Medicare and Medicaid underpayment that they currently shoulder. This creates significant financial stress, especially for hospitals who are already on thin operating margins. In the past couple of years, hospitals in aggregate have had negative operating margins, and now we're going into a place where the headwinds are going to be considerably worse. The increases in uncompensated care are going to force hospitals to make difficult choices, such as reducing certain service lines, postponing investments in technology and facilities, or in some cases, they'll face risk of closure. Ultimately, this financial pressure affects a hospital's ability to serve the entire community. It's not just the uninsured who are affected, but it reduces access and strains resources for all the patients, insured and uninsured, who rely on hospitals for care. And importantly, these uncovered costs will also put pressure on commercial prices and in turn impact affordability. Those comments are about the eligibility and coverage provisions impacts of HR1 and other federal actions or inactions. I also wanted to comment briefly on the changes to provider taxes, which has also gotten a fair bit of play, and which we're of course very interested in mitigating the negative impact of that. In statute today, based on the budget bill that was passed in Connecticut in June, PA 25-168, there's a $375 million increase in the hospital tax in 2027, a total tax of $1.195 billion, and a $140 million increase in payments. So in statute today, hospitals are looking at an almost a $250 million in a reduction in net reimbursement between the tax and the Medicaid payments. We recognize that there's agreement to a lower tax number, and there's an openness to negotiate a different payment number. As it stands today, that's what's in statute. There are a variety of threats that HR1 presents to the tax, it could be that the tax increase, whether it's 375 million or 285 million as agreed upon, that won't be approved. It's equally possible that the payments that are not only supposed to keep hospitals whole, but actually to result in a net benefit to hospitals may not be permissible, so that the tax could be approved, but that the payments that are essential for hospitals to strengthen hospitals, not just hold them harmless, may not be approvable because there are aspects of, because there are questions that remain today as to how they will interpret and apply the rules for states that have an arrangement where we are taxing well in excess of the 6% safe harbor. A lot of attention in the federal discussions about the safe harbor limit at 6%, walking down to 3.5%. There are other requirements that Connecticut has to meet because we have a tax well over 6%. In 2026, our tax is 10.5%. That means that we will need special permissions or approvals in order to have those payments back be approved. And not all of those, and CMS, the feds will have considerable room to interpret and apply those rules in a way that might not be consistent with what our policy goal is. So I wanted to alert you to that, and I'm happy to take any questions you might have.
Thank you. Thank you so much. Senator Lesser.
It's not the first thing we have to focus on because there are much more time sensitive things. But obviously the change to the hospital tax is one of the bigger questions that we're going to have to wrestle with over the next few years. Do you have a sense of how we can sort of engage stakeholders in a robust way to ensure that we're able to adequately fund the Medicaid program? I don't know if those conversations have already begun or if that's something that the legislature can assist with.
I'm sorry, Senator Lesser, is that question unrelated to the tax? So it's just a bigger question about funding the Medicaid program, or?
No, I'm sorry, but related to the tax, right? We're going to see my understanding is that the changes are going to have probably the largest of all of the different changes in HR1.
Yeah.
That is going to be the largest single nut to crack, and that could certainly have a outsized impact on your members. And I'm just trying to figure out, traditionally hospital tax questions have been handled between the executive and your association and your members. And I just was curious if there was a role for the legislature to play.
So there's definitely a role for the legislature to play. Just to contextualize the Connecticut situation a bit. The tax changes and the limits on the upper payment limit for hospitals that were enacted with HR1 will affect other states in a way that's different than us and may immediately, or in very immediately, meaning in relatively short order, it will mean they can't make state directed payments or otherwise reimburse in the way they're doing today. It's conceivable that our tax program, as it was designed, could survive as it was, that we could continue to tax roughly at the level we proposed or with a significant increase, and that it could still be possible to make the payments necessary to strengthen hospitals, and also to do what is already contemplated in the budget bill, which is to use about $144 million of the benefit of the tax for funding Medicaid, some of the increases that were contemplated and such. So it's, if the winds blow in our favor, and there's a lot of reasons to think the feds are not trying to make it possible for programs such as ours to be preserved in their current form, it's possible that we'll be able to do all of what we want to do. We won't be able to grow the tax program, by another 30%, but it does mean that it may be that a tax in the neighborhood of 285 or 325 could be permissible. And it could be that the payments that are the proceeds, the tax proceeds, can be used to support the Medicaid increases that were passed in the budget, and that there would still be money to pay hospitals. So today, we can't say for certain that those things aren't possible in Connecticut. All we can say is we may find in the course of, after we've negotiated with the legislature and the executive branch, sort of what the sort of final arrangement is, we will have to go through over these hurdles of CMS approvals where we may run into trouble. Also, because a lot of states are going to be looking at how they can best preserve their tax and payment programs for Medicaid, the feds may continue to modify the rules in a way that could be, could make it more difficult for all states, including Connecticut.
But if you quoted some dollars that I assume are $20, $25, the cost of healthcare goes up over time. Are we going to be frozen in to 2025 funding levels? And if so, we're going to just have to find additional funding from another source, or is this going to be able to grow over time with healthcare costs and, overall inflation?
So the new figures that were passed for 2027 include a $25 million a year increase. And it could be that might be fine. Again, it's too soon to tell whether that will be disallowed because it wasn't imposed. The requirement is that it be enacted and imposed by the time HR1 was passed. So there is that 25 million, but I'll tell you frankly, you've heard us before talk about the enormous financial strain that Medicaid underpayment plays. And it's our belief the 25 million could support a $75 million payment back to hospitals, which would give us, maybe 2% a year increase. But that doesn't leave any other, anything left over for others. If that 25 million isn't used in its entirety to reimburse hospitals, to be the state share of hospital payments at 75 million, we're not even keeping pace then with nominal inflation. We won't be getting even 2% a year. And we've had roughly 1.5% to 2% a year during the course of the settlement. We will be getting significantly less year over year. So my concern, just to be clear, is that 25 million couldn't go to 75 in order to make it possible not only to reimburse hospitals and continue to provide increments every year, but it's certainly not going to be possible to fund other critical areas of Medicaid.
Got it. And then the immediate crisis is the cut, both on the targeting of specific providers on their ability to provide serve populations, but then also the coverage cut. So, we just heard that 5,000 people are losing coverage imminently on the exchange. And you're going to see an influx of patients presenting at the ERs who have no coverage. And I can't see a way around that. No matter what we do, the size may go up or down depending on what we do in a special session, et cetera. But there's going to be an increase of our uninsured rate, and that's going to have an impact on your members. And I'm just curious, I had a question to the health centers before about potential ways of diverting folks from ERs, but are there models from elsewhere in the country that you can turn to, or some other way we can divert folks who would otherwise present as uncompensated care at the emergency room door?
If somebody's arriving in a hospital truly for an emergency, there's not really another place equipped to handle them if they're an emergency. If it's routine or urgent care under the EMTALA rules, everybody has to be triaged and screened and triaged basically. So there's nobody who can present who can be diverted before. The hospital has to dedicate resources to understanding what are the needs they're presenting with and how to ensure that they're stabilized.
Got it. Thank you, Madam Chair.
Thank you, Senator. Representative Hughes.
Thank you, and thank you for being so patient with us. I just want to clarify, your testimony does not at this point take into account any of the tariff costs on hospital equipment and medication and materials.
Yeah, that's right. So I referenced a few things, advancements in technology and investment in facility, but without question, all the supply chain costs will be affected by tariffs, and that is a major consideration that I didn't mention, but you're right to.
And we don't have a plan for absorbing those costs in any of these scenarios at this point. Like, who does that get passed along to?
That's right. In order for hospitals to continue to be able to cover their expenses, there's really nowhere to go except through to their commercial payers. That's the only way to balance the books.
And finally, this has been an incredibly complex hearing to try to get the details, but I feel like we've underemphasized the behavioral health costs, which already were underserved, by providers in the community, and already families are frantic with wait lists and wait times for emergency behavioral health needs. How do you see HR1 impacting that in the hospitals?
Well, behavioral health is a major factor contributing to emergency department use today,
Right.
whether as a comorbidity or as a primary presenting problem. And the significant challenges that loss of coverage or loss of access will present means more individuals ending up in emergency departments presenting with behavioral health problems. That's a really big deal, as you note. And it's, I think, fair to say that just from an epidemiological perspective, if you have this much more strain on communities and people who have less, that in and of itself is a risk for more mental health need.
Thank you for that. And just to clarify, we are seeing with less resources and care in the community, more ill-equipped first responders, police, law enforcement, and emergency room personnel, ill-equipped to handle major behavioral health crisis, and therefore can be really catastrophic in those encounters, either deadly or overuse of force, involvement in the justice system, or overuse of chemical restraints, just to keep everyone safe. And that does not sound like keeping America healthy to me.
I wholly concur.
Thank you.
Thank you, Representative. Representative Shake.
Thank you, Madam Chair. Good afternoon, Mr. Schaefer.
Good afternoon.
Thank you for hanging in after over 5 hours of a hearing opportunity, which I appreciate. So thank you for being here. Just a few questions. So because you've been here all day, the overarching theme here is that there's going to be less covered healthcare, which then impacts our whole health system, whether it's the hospitals or CHCs. We even talk about like AMR and our ambulance services and how lack of Medicaid will then negatively impact them, right? And their ability and significant loss of revenue. But a long time ago, before I ever became a nurse, I saw a documentary called Sicko. And that was, yeah, that was a pivotal moment for me, because before being in politics or elected service, it was, I want to help people. I just need to figure out how. And in that documentary, the leading cause of bankruptcy for American families, residents here in this country, was medical debt. So even though Connecticut has done a great job of expanding, codifying our ACA, increasing accessibility for our vulnerable patient populations through Medicaid or Husky, now all of this 5-hour hearing has redirected me back to that moment like 14 years ago, where we're just barreling rapidly fast towards creating not just a healthcare, well, we're not creating it, but HR1 creating essentially a healthcare system potential collapse, but an economic collapse for our residents, not just here in Connecticut, but across the country. So we need to figure that out. So thank you for sharing some of your insight. If there is no resolve that the Connecticut Hospital Association considers to be appropriate in your view, and you talked about reduction of service lines, things like that. As a nurse myself, and I have many colleagues and friends that work in healthcare also, no one works in an institution office space right now where I have heard anyone say, we are adequately staffed. We have more than enough trained, appropriate personnel to handle the daily patient flow and responsibilities. So my question to you, if you can answer this or you have an idea, if there are such significant revenue losses or subsidies like federal Medicaid funding, what have you, I hope that the cuts, for lack of a better description, are not done first to the medical staff that you have in the hospitals, because we are all trying to do our best to take care of our patients. And my suggestion would be to look at administrative costs within those networks. And that's something way above my pay grade. But because the workers are doing everything that they can under the conditions that we currently live in, right, to do what's best for our patients. So I hope that you go back to your colleagues and you can say Representative Shake made that suggestion of evaluating, assessing, because behavioral health was brought up by my colleagues as a concern, and the ER is like everyone dumps everything into there because there's nowhere else for people to go. But not every single healthcare institution across the state is equipped to receive and then adequately take care of people who are exhibiting behavioral health needs. Things have changed since COVID, right? Whether we're talking about pediatrics or psych wards, not everybody just go to a hospital and receive all the same level or type of care that you may need. And patients don't know that because they're coming in with an emergency. So it's just something that, the reality is when people need help, we have our EMTALA laws, which you referenced several times. And then we have to figure out how that's going to possibly also be applied to, if not, to our federally qualified health centers or urgent care centers. So in your opinion, and there's many different areas within healthcare that need attention or reassessment, reevaluation to figure out, with service lines potentially being reduced, because how are we going to pay for it? Is it going to be the consumer or the patient who thinks that they have adequate healthcare insurance, period? But from what I'm hearing, and my other colleague led into the whole tariffs conversation. So the procurement process that the institutions within the CHA have to go through, who's going to pay for that at the end of the day? if you have a list of suggestions of where those cuts specifically, or reductions, I should probably say, I think that would be more hopefully appropriate, would be coming from within the hospital systems. Do you have a response? That was a lot, I know, but I only have 3 questions.
Yeah, well, you touched on a number of, I think, critically important points, Representative Shake. I think foremost, the hospitals are committed to protecting and preserving their workforce, and doing whatever they can to ensure that the experience of being a healthcare worker is a positive one, and that means protecting against workplace violence. It means adequate staffing to ensure that, because a lack of staffing and being overworked and having demands that you can't meet is something that it's in nobody's interest to have that happen. So protecting and preserving the workforce is number one priority, which means that they will necessarily look at all other places to administrative, non-clinical staff, but also to other administrative solutions. And it might be for care efficiencies or introducing technology to introduce time-saving enhancements, renegotiating supply chain contracts so that you are getting the best supply costs you can. I just want to be clear that they have been doing, with hospitals coming off of a couple of years of negative operating margins statewide, it's not like they're just turning their attention to this. Hospitals have been looking to reduce unavoidable costs, find administrative efficiencies as much as possible in order to regain strength as institutions. And so it's very difficult to suddenly have a new plan for direct tariff costs that are passed through to hospitals as purchasers in areas like drugs and supplies. And so they will continue to, I think, look at every potential avenue to reduce expenses so that these challenges don't translate into higher costs for others. But there's only many places they can go. It's one of the reasons we have been so focused on Medicaid underpayment. It's a truism at this point that fundamentally underpaying Medicaid, and our shortfall in Medicaid is 60% higher than the rest of the nation, that is an issue that continues to be unaddressed. And so the biggest way to help hospitals with their financing is the place that is within the legislature's control, and one that is federally matched. So you're helping with costs by figuring out how to better invest through the Medicaid program. And so that is something it's an ongoing liability, and I would be missing the most important point if I weren't to remain laser focused on this issue of Medicaid shortfall. We are a state that uses the tax to fund other parts of the Medicaid program, but by and large, in other states where they use the tax to generate reimbursement increases for hospitals, it doesn't happen here. That's why we have a 60% higher Medicaid shortfall. So that is something, I think, in addition to the important steps that the legislature can take to shore up covered Connecticut when the loss of subsidies, and possibly to help with subsidies to keep people covered in other areas where that this reimbursement issue, that we maximize the extent to which the tax that we can have on hospitals in Connecticut is used to keep hospitals strong and to pay have Connecticut pay at least its fair share to supporting the care that's being provided to Medicaid.
Thank you. That was very helpful. I think first and foremost, I think, correct me if I'm wrong, but everybody up here that's currently on Health and Human Services, we all advocated for increasing the Medicaid reimbursement rates. And I'm sure we'll continue to do so. But I'm also really happy to hear that, in the event of if there's reduction, compartmentalizing of services, et cetera, that the aim of the CHA is to not go after or reduce the workforce that is patient facing and clinical. As you said, it would be a reassessment of administrative, non-patient facing. There's multiple other positions within networks that would be addressed. We don't want anyone to lose their job, but this is a huge gap financially that's going to have to be filled somehow or addressed. So appreciate your time. Thank you.
Thank you.
Thank you. Representative Dathan.
Thank you so much. And thank you for your presentation and all your work that you do in my MAPOC care management committee subcommittee that I work on. One of the things that, you kind of highlight is the hospital tax. And I do feel that this is something that I would like to see us dive into more within the MAPOC organization so that we can kind of understand how we can do better for our residents and our providers to be able to get them the rates that they need in order to continue the services no matter where they are in their state. So keep an eye out. This is something that I'll be bringing up with my MAPOC committee, and hopefully we can move the needle a little bit forward and start the discussions on this and look at what other states are doing so that we can have improvement. So just wanted to say thank you again, and I'll see you next week at Care Management.
Thank you.
Thank you, Madam Chair.
Thank you. One final thing. Today was focused on Medicaid and SNAP, and I appreciate you staying focused to that. Has the Hospital Association put out any additional research, or will you be putting out additional research on kind of the totality of the impact of what's going on federally on hospitals?
We are putting together our best estimate of the impact of the federal changes on coverage and on hospitals in particular, and with an eye towards some of the near-term impacts and how those are going to unfold in 2026, 27, 28. A lot of the numbers that we've seen the Comptroller's Office put out and Access Health Connecticut and Medicaid are about the 2034 view. And we're really interested in being able to look at how this will occur over time. And some of these problems may snowball, right? So as you talk about folks who are maybe healthier and can afford not to keep their Access Health Connecticut, it makes that risk pool more significant, and it makes the products more costly, and that could lead more people to lose their coverage. So I think that there could be I think we expect that these projections will take time to unfold. We need to understand near term, 27, 28. That's what hospitals are asking about today. Is we're budgeting for next year. That tax increase, $375 million, is basically 10 months from now. We're budgeting for increases in charity care and the increase in the tax already in a year.
Okay, thank you. So if and when you have information, if you can reach out to us, that'd be fantastic, because we'd love to continue these conversations.
Thanks. I would just add, Representative Gilchrist, that our ability to make estimates depends a lot on what the state's sort of sharing out what they're going to do, because our assumptions are only as good as what policy policies DSS is going to implement and you all are going to implement at the legislature. But happy to share what we have when we have it. Thank you.
Great. Thank you. Well, thank you so much for your time today. Thank you to everyone for participating in this very important forum. We have a lot of follow-ups to do, and yes, any final remarks from? Okay. All right. Thank you, everyone. Have a great afternoon.
Bye-bye.